Shall we start? Good morning to all my respected teachers, seniors, and my dear colleagues. I am Dr. Shobha Gaikwad. I am working as an associate professor in the Department of Anatomy of Topiwala National Medical College and Nair Hospital. I am welcoming all to this webinar on chemical neuroanatomy. We are conducting this webinar on the occasion of the centenary year celebration of Nair Hospital. The Department of Anatomy is conducting this webinar in collaboration with the Department of Psychiatry, Medicine, and Neurology. We are starting this program with a valuable message given by our respected dean and Director of Medical Colleges of MCGM, Dr. Ramesh Bharmal sir.
To all the faculty and participant of the webinar on chemical neuroanatomy. I would like to congratulate the Department of Anatomy for arranging this webinar in collaboration with Department of Psychiatry, Neurology and Medicine. It is a very nice example of collaboration between preclinical and clinical departments for exchange and enrichment of knowledge. This is in alignment with the principles of vertical integration as suggested by National Medical Council. I am told that apart from the faculty, participants across India who are attending the webinar on Zoom, there are many students who are attending this webinar on Facebook Live. I would like to advise the students who are attending this webinar on Facebook Live to take full advantage of this webinar to clear their concepts on neuroanatomy, neurotransmitters and the associated diseases. All the best to all of you. Have a nice day of enrichment of knowledge. Thank you very much.
Thank you, sir. Now, it is a great pleasure to introduce our first speaker of the day to this webinar, Dr. Yuraj Mosley. Sir has done MS and DNB in human anatomy from most prestigious college, that is Grand Medical College and JJ Group of Hospital. Sir has received a fellowship in medical education. So, over to Dr. Yuraj Mosley for the first session of this webinar, that is Introduction to Chemical Neuroanatomy.
So good morning, all of you. And my respectful obeisances to all my teachers also who are there and my seniors who are there and attending these workshops. Now, this is one of the slides which shows the structures of various neurotransmitters. And if you see here, the first three, adrenaline, noradrenaline, dopamine, they have this catecholamine link. And if you see lower down, GABA, glutamate, they are just amino acids. While this one, the acetylcholine, it is very difficult to put acetylcholine in any one of these groups. Now, before 1920, it was thought that electrical signals, they are the ones which are passing from one nerve to another through direct contact. But it was in 1921 that Otto Loewi, who was a professor of pharmacology in Austria, he gave evidence that there are chemical mediators which are released in the synaptic cleft. And the same effect can be brought about if you introduce a chemical in the cleft, you get the same effect as the neurotransmitters being released in the cleft. Why chemical neuroanatomy? And all of us know Munna Bhai talking about chemical locha. And that chemical locha is there in the brain of many people, and especially in the field of medicine, because our pharmacology and medicine textbooks, they talk about the signal transmission, but the anatomical basis of this needs to be clarified, and that's what the purpose of this whole webinar is. Neurochemicals, there are various ways of classifying neurochemicals, and I'll be talking one of the few ways of classification. One is you can classify them as neurotransmitter, neuromodulators, and neurohormones. Neurotransmitters can be further classified into facilitatory and inhibitory neurochemicals. Even the neurohormones can be further classified into chemicals released by the body acting on the neurons, like cortisol, adrenaline, and chemical released by the neuron and acting on the body, which are of two types. The paracrine ones, which act locally, the examples of which are gastrin, secretin, and the endocrine ones, which act on distant organs like ADH and oxytocin, which are secreted by the neurons. What is the difference between a neurotransmitter and a neuromodulator? A neurotransmitter is the one which is released by the neuron, and it sends signal to the next neuron, while neuromodulator is a substance which is released by the neuron, which alters the effectiveness of the signal transmission. A neurotransmitter is released in a synaptic cleft, while a neuromodulator can be released in any area of the neuron. Binding receptors of a typical neurotransmitter is inotropic or metabotropic, while a neuromodulator always binds with metabotropic receptors. The speed of action of a neurotransmitter is very fast comparatively. A neuromodulator is very slow, but it lasts for a long time. A neurotransmitter can be reabsorbed, while a neuromodulator is not reabsorbed by the presynaptic neuron. This is a picture of a typical synaptic cleft, where we can see here the neurotransmitter vesicles, and they are being released and they are getting attached to the receptor proteins. This is another way by which neurotransmitters can be classified, more based on their structures. Some of them are just amino acids like glutamate, aspartate, GABA, glycine. Some are gasotransmitters like nitric acid, CO, H2S. Some are monoamines like dopamine, norepinephrine, epinephrine. There are trace amines also, which help the monoamines to do their action, like tyramine. There are peptides like oxytocin. There are purines like ATP, adenosine, and again acetylcholine falling in none of these above mentioned categories, and therefore we have put it in other category. Another way we can say it can be of small molecules which are rapidly acting transmitters like class 1, acetylcholine, class 2 of amines, where epinephrine and dopamine, serotonin all are there. Amino acids like GABA, glycine, glutamate, and class 4 is of nitric acid. It's a gas, so we have put it in class 4. Neuropeptides, now these were rapidly acting transmitter. Now we are talking about slowly acting transmitter. They are the hypothalamic releasing hormones. There are the pituitary peptides, thyrotropic releasing hormone, the pituitary peptides like beta endorphin, prolactin, luteinizing hormone. The neuropeptides, slowly acting transmitters, mainly acting on the gut and brain, substance P, gastrin, cholecystokinin, the vasoactive intestinal polypeptide, while those acting on the other tissues like angiotensin 2, bradykinin. So you can classify the neurotransmitters in that way also. Now glutamate, why I'm talking about glutamate first, because glutamate almost constitutes 90% of the neurotransmitters in the brain. It's excitatory. And a very interesting fact about glutamate I would like to mention is glutamate is very chemically identical with monosodium glutamate, which is there in all the flavored food which is available in the market, which the junk food which the children are eating. And that's because it is similar to glutamate, it causes excessive excitement in the children. And we today talk about attention deficit disorders. And the glutamate, the monosodium glutamate, which is responsible in the junk food, is the one which is responsible for this attention deficit disorders and overexcited hyperactive children. It's the amino acid. And similarly, the gamma aminobutyric acid is also amino acid, and it constitutes almost 9% of the neurotransmitters. So that means glutamate constituting 90% and gamma constituting 9%. They almost contribute to the 99% of the neurotransmitter. Remaining 1% now I'm going to talk about. These are the catecholamines. You can see the catecholamine ring in all of them, which is common: dopamine, adrenaline, and noradrenaline. These are indolamines. You can see 2 rings over here: serotonin and imidazole transmitters like histamine. Acetylcholine, again a very complex structure, and that's the reason we cannot put acetylcholine in any one of the above mentioned previous categories. Acetylcholine assists in motor function and is also involved in memory. Normally we just put acetylcholine as one of the secretions important in the autonomic nervous system, but has many other functions too. Now going to the other neurochemicals like the trace amines, which act as neuromodulators for the monoamine neurons. Now nitric oxide, which is a gas, but it also acts as a neurotransmitter. It basically very important in the erectile tissues where it acts. Endocannabinoids, these are the ones which give us a feel-good factor. We all know about the cannabinoid addictions, and we also have endogenously secreted endocannabinoids, which are released in the hypothalamus, amygdala, basal ganglia, and the cerebellum. They give us a very feel-good kind of feeling, and the feel bad or feeling is given by the eicosanoids. Not exactly feel bad, but they are the ones which produce prostaglandins via the arachnoid acid cascade, and that's what produces inflammation. Although we may feel bad because of the inflammation, but that inflammation is necessary to indicate that our body needs rest. There are neuropeptides like orexins. We have heard of the term anorexia. Anorexia means that a person does not feel like eating, and opposite to which are these hormones or orexins, which are responsible for appetite, arousal, and reward, many other functions. So it's not that neurochemicals means always conducting impulses. They are responsible for appetite also. There are neurohypophyseal hormones like vasopressin, oxytocin. Now, oxytocin, we normally just feel that oxytocin is the one which is needed for delivery and all, but it has many other functions like social cognition, trust, pair bonding. It modulates the maternal behavior. And opioid, we all know of the opioid addictions, but there are opioids secreted inside our body also, like endorphins, the enkephalins. Neuropeptides. Now these neuropeptides are biomolecules, and they are kind of small proteins and responsible for growth. So now we are going one step ahead, that these neurochemicals, which are also responsible for growth, and for the nerve growth, like nerve growth factors like neurotropin 3, neurotropin 4. There are insulin-like growth factor 1, and many other, there are brain-derived neurotrophic factors which are responsible for the growth of the nervous system also, which are secreted inside the brain. So neurochemicals are responsible for growth also. Another example of a typical synaptic junction where we can see the voltage-gated calcium channels also. Dale's principle, I know looking at the slide, the first thought that comes to your mind is Dale's principle is outdated, I know that. But Dale was the one who stated that a given neuron contains and releases only one neurotransmitter and exerts a similar functional effect on all of its termination site. And that's what people believe, that Dale what Dale said is true, and we actually have respect for him because he is a great scientist. But then came the co-transmitters. And what are the co-transmitters? A substance that is released from the nerve ending along with the primary neurotransmitter, and it modifies the action of the primary neurotransmitter. Like, for example, the vasoactive intestinal peptide, it functions as a co-transmitter with the acetylcholine at the cholinergic synapses. So these are the examples of co-transmitters, and that's where the Dale's principle failed. Because of presence of co-transmitters, the action of a neurotransmitter getting modified. So that's all about the neurotransmitters. These neurotransmitters which we were thinking are only responsible for passage of signals across the synapses. It's not like that. The neurotransmitters are responsible for our emotions, they are responsible for our growth, and they are responsible for our hunger also. With that, I end my short introduction on this topic of introduction to chemical neuroanatomy, chemical neurotransmitters. Thank you so much.
Good morning, everyone. I am Dr. Mrunalini Vatsavare, Assistant Professor in Department of Anatomy at Topiwala National Medical College. Our next speaker for the webinar is Dr. Nagaraj Pai. He has completed his UG from Telna Medical College and MD Anatomy from Topiwala National Medical College, where he achieved first rank in MUHS. Presently, he is working in our own institute as Assistant Professor in Anatomy. He is a university-approved PG teacher and has many publications in national and international journals to his credit. So over to Dr. Nagaraj now. Thank you.
Morning all, thanks for inviting me for the webinar. I'll just start with the slide of autonomic nervous system. Autonomic nervous system, as you all are aware, of made up of sympathetic and parasympathetic component, which you have all studied in your yesteryears. So now let's begin how to get an overview of the central nervous system. These are all the receptors which are bringing the information from the periphery, either from the sensory areas or the visceral stimuli. They become the afferent division, gets the information towards the brain and spinal cord, and then it gets processed and forms an output. This output is an efferent division. This efferent division can be voluntary or involuntary. The voluntary ones are the somatic nervous system, which via motor neurons influences the skeletal muscle. The autonomic nervous system via the sympathetic and parasympathetic involves and influences the smooth muscle, cardiac muscle, and exocrine glands. There is another nervous system called as enteric nervous system, which influences the digestive tract. It is also regulated by sympathetic and parasympathetic. Now let's begin with our topic. As you all are aware that the neurons or the cell bodies are located in the brainstem or spinal cord. From there, the preganglionic neuron comes out. It relays into the ganglion, and from the ganglion, the postganglionic neurons influences the effector organ. This influencing effect is via neuroeffector transmitter or neurotransmitter. Why do you require this autonomic nervous system? This autonomic nervous system is responsible for maintaining normal homeostasis like digestion, circulation, respiration, excretion, and it is influenced via limbic lobe through hypothalamus. It consists of two neurons, which I already discussed, preganglionic and postganglionic. Preganglionic is also called as connector, while postganglionic is also called as effector. This is a broad prototype diagram which shows what is the sympathetic and parasympathetic. The sympathetic is the thoracolumbar outflow. It begins from T1 to L2, intermediolateral column, relays in the ganglion called as sympathetic ganglion, which lies paravertebral, and the postganglionic fibers is influencing the smooth muscle and the glands. The parasympathetic, also called as the craniosacral outflow. The craniosacral begins from cranial nerve nuclei 3, 7, 9, 10 and the sacral component from S to S3, S4. They relay in the parasympathetic ganglion, which lies near, in, or around the organ concerned, and via the postganglionic pathway influences the smooth muscle and glands. Sympathetic and parasympathetic can be easily explained via this diagram, in which sympathetic influences or it is brought about into action via fight or flight stimulus, in which our body is completely directed to avoid any harmful event which is occurring. For such thing to happen, there is 1:10, that is, one preganglionic influences 10 postganglionic neurons and bring about a widespread effect. Similarly, the release of epinephrine or adrenaline via the adrenal medulla also brings about the diffuse effect. As long as the parasympathetic is concerned, on a lazy Saturday afternoon, you're taking a deep, good nap. It is rest and digest, in which the one preganglionic influences the one postganglionic neuron, and the diffuse effect is not seen in parasympathetic pathway. Although the image you can appreciate that both are acting like a tug of war, but they are very important to work together to maintain a normal homeostasis. All of the organs in the body are innervated via both sympathetic and parasympathetic for dynamic homeostasis, except few which is only involved by sympathetic system like adrenal medulla, kidney, pilomotor muscles, blood vessels, and sweat glands. This is a image you can appreciate to see that the sympathetic as well as parasympathetic influences the system. We'll take few examples like the salivary glands, in which the sympathetic will make the secretion as thick and viscous, while the parasympathetic makes it watery. The heart is influenced by sympathetic to increase the rate and contractility, while parasympathetic will have an opposite effect. As long as the gastrointestinal tract is concerned, the sympathetic causes decreased motility and increase the tone of sphincters so as to help in circumstances like a lion or some event which is falling behind you, so to protect yourself, while the parasympathetic has an effect which is opposite to it. As long as the blood vessel is concerned, the sympathetic causes a skeletal muscle vasodilation, while it causes vasoconstriction in skin, mucous membrane, and splanchnic area blood vessels. Sympathetic causes release of adrenaline and noradrenaline via adrenal medulla and causes a bronchodilation of trachea. Now we'll go into see how the molecules or chemical signals takes place between one cell to other. For this, we should understand there is an endocrine hormones in which a cell releases the hormone and the effect is widespread throughout the body. The paracrine hormones are one in which the chemicals are released and it transmits to the nearby cell. The local modulators like histamine and prostaglandin, it involves or influences the adjacent cells, while the neurotransmitter, which are topic of concern, is influences the next cells, that is the immediately next one, like the preganglionic influencing the ganglion or the postganglionic neurons. So there is next one, the next cells. So neurotransmitters are a topic of concern. We'll discuss this. Out of the important neurotransmitters, the primary neurotransmitter in the autonomic nervous system is acetylcholine and noradrenaline. The neurofibers which releases the neurotransmitter are either said to be cholinergic fiber when they release acetylcholine, or adrenergic fiber when they release noradrenaline. Chemical signals are one or neurotransmitters. Once they are released, they bind to the receptors. Now, what are the receptors and how they act? The receptors are primarily classified into ionotropic receptors and metabotropic receptors. The ionotropic receptors, the primary example is the nicotinic receptor in skeletal muscle, in which when the agonist binds to the receptor, it increases the sodium channel and thereby causing depolarization. While metabotropic receptors are second messenger G protein coupled receptors, in which once the agonist binds to the receptors, it brings about some change in the cell membrane to cause release of adenyl cyclase and inositol triphosphate, thereby causing some kind of phosphorylation in the cell. The examples of this are muscarinic and adrenergic receptors. To take home message is ionotropic receptors are nicotinic, while metabotropic receptors are muscarinic and adrenergic. Now, we have all understood about the receptors. Now we'll concentrate on a topic towards cholinergic neuron. What is cholinergic neuron? Is one which releases acetylcholine. Now, what are they present or where are they seen? They are seen in the preganglionic fibers which are released and they are going towards the adrenal medulla, releasing acetylcholine. The second one is preganglionic sympathetic and parasympathetic, the postganglionic parasympathetic, and the neuronal cell bodies which are coming from the somatic and influencing the skeletal muscles. So these are the sites where the acetylcholines are released. Once this acetylcholine is released, it now has to attach itself to the receptors. Before going to that, we understand how the neurotransmission occurs. The choline is taken up by the neuronal cell body. It is converted via acetyl-CoA transferase to form acetylcholine. These acetylcholine are now packed into a vesicle and stored. When the neurotransmission occurs, the action potential is transmitting towards this axon. The calcium-gated channel opens, causing the release of the synaptic vesicle into the synaptic cleft. Now, what are the output and where it has to go? The acetylcholine either can bind to the receptors, either it could be the nicotinic or muscarinic receptors, or it can attach itself to the presynaptic receptor. Next, what is the fate of this acetylcholine? The acetylcholine can undergo breakdown via forming acetate and choline via acetylcholinesterase, and this choline is again taken up by the neuronal axon. Important to remember is you have heard about Botox and its treatment in case of wrinkles seen in age-related age phenomenon. In such cases, botulinum toxin prevents the release of acetylcholine in the cleft, thereby preventing formation of wrinkles. However, another example is spider venom, in which there is increased release of acetylcholine and attaching itself to the receptor, bringing about muscle contraction. So our topic is understanding what is the physiology, anatomy, as well as understanding what is the implied aspect therapeutically. Now, once the acetylcholine is released, it has to bind to the receptors. There are two receptors of concern, is muscarinic and nicotinic. The muscarinic is classified into M1 to M5. It has got high affinity to acetylcholine as well as muscarine. What is muscarine? Muscarine is an alkaloid that is present in certain poisonous mushrooms. Once this receptor is activated, it brings about various effects in heart, smooth muscle, brain, and exocrine glands. The next receptor was nicotinic receptors. The nicotinic receptors are two. One is located at the neuromuscular junction, and the name which we give is NM, N capital small m. And another one is present in the ganglion and adrenal medulla along with CNS, called as the NN, N for nerve, N for muscle. So neuromuscular NM and NN for the ganglions. Now, we are talking about the analogs which now bring about effects which is similar to parasympathetic. What are they called? Parasympathomimetic, or other name which can be given as agonist. There are two types of them, a direct acting and an indirect acting. Indirect acting can be reversible and irreversible. Now we will concentrate on a direct acting parasympathomimetic. So direct acting parasympathomimetic, as the topic is huge, we are going to concentrate on few aspects which can be used clinically. One, which is commonly known, is endogenous produced cholinesters like acetylcholine. One could be synthetic esters of choline like methanacol. And the third one is naturally occurring alkaloids like pylocarbin. So we'll take one by one. We'll start with acetylcholine. The acetylcholine is a widespread neurotransmitter. All are aware that it is inactivated by cholinesterases, rapidly inactivated, so lack of therapeutic importance. However, the few important aspects we can understand over here is the SA node has an inherent rhythmicity of 100 beats per minute, and the rate is 100. It has to be regulated by vagus nerve. The vagus nerve releases acetylcholine and influences the SA node, thereby bringing about decrease in heart rate and cardiac output. Another important is vasodilatation. Acetylcholine, once it's released, it influences the endothelial cell to produce nitric oxide from arginine to bring about smooth muscle relaxation, thereby causing vasodilatation. And the third important effect is meiosis. Although there are various other things, but it is beyond the scope of our topic to complete everything. So we are going to concentrate on few of the aspects which is brought about by acetylcholine. You have all heard about atonic bladder. Before going it, let's understand how is the bladder regulated. It's a sympathetic pathway and a parasympathetic pathway which influences the bladder activity. The sympathetic activity via T12 to L2 brings about relaxation of the detrusor muscle and the constriction of the internal urethral sphincter. The parasympathetic via S2, S3, S4 has a vice versa effect, thereby causing a complete evacuation of bladder. In case of lesion of the spinal cord, the reflex of bladder emptying is absent. In such cases, the bladder accumulates the urine and only 100 to 120 ml of urine is eliminated. The rest is retained, thereby increasing the chances of urinary infection. This is most commonly seen in postpartum or postoperative with non-obstructive urinary retention. Hence, to avoid this, we give methanacol, which has got good muscarinic activity. It causes constriction or contraction of the detrusor muscle, relaxation of the sphincter, and complete evacuation of the bladder. Thus, we understand what is the therapeutic use of methanol, which is a synthetic cholinesterase. The last one, naturally occurring alkaloid, is pylocarbin. This pylocarbin has a good muscarinic activity, brings about contraction of ciliary muscle and rapid meiosis, bringing about opening of trabecular meshwork. This is applied aspect which could be used in reducing the intraocular pressure. As you all aware, when the trabecular meshwork opens, the fluid goes out, aqueous humor, thereby reducing the pressure. And this is used in both open angle and close angle glaucoma. So in this, we have completed the direct acting cholinergics. Now we are going to act on indirect acting. Indirect acting could be reversible and irreversible. What do you mean by reversible and irreversible? Acetylcholine is broken down by the acetylcholinesterase into acetate and choline. If this mechanism is prevented, we thereby increase the level of acetylcholine at the receptors. Myasthenia gravis is a condition in which the autoimmune antibodies are directed against the receptors. When this receptors are targeted, there is decrease in the action of this acetylcholine. So how can we prevent it? We cannot prevent it. How can we treat it? By treating is increasing the acetylcholine level. This acetylcholine level can be increased with the help of neostigmine. Thus, it has got a therapeutic importance in myasthenia gravis. However, this action can be reversed over a period of time. Hence, it is an reversible indirect acting cholinergic agonist. Next is irreversible anticholinesterase agents, which we're talking about. You might have aware during yesteryears, during military operations, there was a nerve gas poison. This nerve gas poison is to cause permanent damage. It was extremely toxic, and this was the mechanism for that usage. It was organophosphates, which are synthetic, which binds to that acetylcholinesterases, preventing the breakdown of acetylcholine, thereby prolonging the action of acetylcholine. Similar compounds which could be used in our household activity is parathion and malathion or as an insecticide. A person, if an individual consumes this in excess amount due to some by mistake situation, then it can cause organophosphate compound poisoning, which can be treated with the help of pralidoxime. This pralidoxime has got an inherent activity called as acting the nicotinic receptors by blocking it. Also, we can use atropine to prevent the muscarinic side effects. So take home message was cholinergic agonist, direct acting and indirect acting. Direct acting we did. Now indirect acting was reversible and irreversible. Now analogs which act on the receptors and has no effect or produces an opposite effect because of the sympathetic pathway is because called as the parasympatholytic or an antagonist. Now, where are the antagonists acting? The antagonist can act on the nicotinic receptors. Where are the nicotinic receptors present? The nicotinic receptors, as we already discussed, is present in the ganglion. So it could be said as the ganglion blocker. It is present on the skeletal muscle. So it could be neuromuscular blocker. And a muscarinic receptor is present elsewhere. And this it is anti-muscarinic blocker. So this we have got three things: a nicotinic blocker and a muscarinic blocker, nicotinic blocker on the ganglion, and the neuromuscular junction. Our concern of importance over here is anti-muscarinic agents like atropine and scopolamine. In the image, you can appreciate the acetylcholine binds to the muscarinic receptor. If few compounds which binds to the receptor and doesn't produce any effect, then that is called as an antagonist, like atropine and scopolamine, which binds to the receptor and has got no effect. Atropine is an alkaloid having only muscarinic activity, or it acts only on the muscarinic receptors. It acts both centrally and peripherally. In addition, this has got an effect on the neurons which are innervating the sweat gland, and hence atropine causes reduction in secretion. Other therapeutic uses could be measuring refractive errors. Individuals, when they go for checking of refractive errors, sometimes the inherent contraction of the muscles causes difficulty to appreciate a correct refractive error. In such cases, atropine is used. It produces the dilatation of pupil, causes mydriasis and cycloplegia, because the accommodation mechanism is prevented, thereby giving a good refractive error. During some muscular contraction which occurs in the gastrointestinal tract, this could be used as an antispasmodic, as atropine is also useful for reduction in treatment in bradycardia by increasing the heart rate. And we have seen in the previous slide in organophosphate compound poisoning, we use this atropine as an antidote. The another one of topic concern is copalamine. This copalamine is useful for motion sickness in post-operative nausea and vomiting. Other advantages of anticholinergic agents is used as bronchodilators, in treatment of bronchospasm associated with COPD. We have done with the anti-muscarinic agents. Now we are going on to neuromuscular blocking agents. In previous years, the South American hunters in the Amazon region used to attack and paralyze their prey using the curare group of drugs. This curare group of drugs used to block the nicotinic receptors at the neuromuscular junction, preventing the action, thereby causing paralysis. So this is our motif called as neuromuscular blocking agents, which are classified as non-depolarizing or depolarizing. The non-depolarizing is the curare group of drugs. Example are pancuronium and rocuronium. And depolarizing drugs are classified in further acting on phase 1 and phase 2 mechanism. The phase 1 is one in which the succinylcholine binds to the receptor, brings about depolarization. Over a period of time, it continues to adhere itself to the receptor and doesn't allow it to repolarize, thereby prolonging the action. And this is called as flaccid paralysis, which is seen in succinylcholine. Succinylcholine is only depolarizing agent which is used in as a muscle relaxant. It has a rapid onset of action and acts for only few minutes. It is useful for endotracheal intubation, which is for induction of anesthesia. It could be broken down by plasma pseudocholinesterases. However, in few individuals, due to genetic variants, this pseudocholinesterases is abnormal, thereby prolonging the action of this succinylcholine, which should be aware during usage of succinylcholine during endotracheal intubation. We have seen the parasympathetic ones. Now we see the sympathetic ones, beginning with adrenergic neurons. What is adrenergic neurons? The adrenergic neurons are one which releases adrenaline, preferably noradrenaline. This noradrenaline production can be seen in this image. The tyrosine is taken up by the neuronal cell body. It is then hydroxylated into dopa, further decarboxylated into dopamine. This dopamine is hydroxylated further to noradrenaline. This noradrenaline is stored in the vesicles near the synaptic cleft. When the action potential is traversed, there is increase in the calcium-gated channel, causing the fusion of the synaptic vesicles with the synaptic cleft and release of this norepinephrine or noradrenaline. The noradrenaline can either attach itself to the postsynaptic membrane, which is the receptors, to bring about a response. Another thing is it could act on the presynaptic receptor, thereby reducing the output of this noradrenaline. This is a feedback mechanism predominantly seen via alpha-2 receptors. The alpha-2 receptors are present over here and they prevent its action, thereby reduction of release of this noradrenaline. What are the other fates of this noradrenaline? The noradrenaline can be broken down by catechol or methyl transferase into inactive metabolites and excreted in urine, or it could be taken up by the neurons, again metabolized by monoamine oxidase into inactive metabolites, or this noradrenaline can be taken up inside the vesicles again for further utilization. So this is the way in which the noradrenaline is processed. Now we have seen the noradrenaline, how it is released. It acts on receptors. The receptors are called as alpha receptors and beta receptors. The alpha receptors and beta receptors are stimulated by this adrenergic neurons and bring about the effect. Where are they seen? They are present in the central nervous system and also in the sympathetic nervous system, where they serve as a link between the ganglion and the effector organs. What are the receptors and what they bring about? The alpha receptors are classified into alpha 1 and alpha 2, beta 1 and beta 2. The alpha 1 brings about vasoconstriction. Because of the vasoconstriction, there is increase in the peripheral resistance, thereby increasing the blood pressure. Alpha 2, as we have already seen in the image, blocks the release of norepinephrine, thereby further reduction in the release of norepinephrine, also release of acetylcholine. The beta 1 receptor is present in the heart. When it is stimulated, it brings about increase in the rate and force of contraction. The rate thereby brings about tachycardia and increases the cardiac output, also increases the cardiac contractility. Beta 2 acts on the vessels, bringing about vasodilatation. Once the vasodilatation is brought about, it reduces the peripheral resistance, causing reduction in blood pressure. Also, an important aspect which you have seen in asthmatic patient treatment is the bronchodilators. So now we will proceed with this knowledge for analogs and antagonists. We are talking about some analogs which bring about an agonist activity called as sympathomimetic or agonist. It could be classified as direct and indirect. The direct one brings about the release of the direct one is acting directly on the receptor to bring about an effect. So this is called as direct receptor agonist, called as adrenaline, noradrenaline, isoprotanol, and phenylephrine. The indirect one can act via two mechanisms. Either they increase the release of norepinephrine, thereby increasing the noradrenaline in the cleft, that is mainly seen in amphetamines, or it can block the reuptake of the noradrenaline inside the neuron. This is seen in cocaine. So we have seen sympathomimetic or agonist, which brings about direct action or indirect action. There are few adrenergic agonists which can be classified according to their names, like catecholamines and non-catecholamines, depending upon the chemical architecture. The catecholamines are one which are adrenaline, noradrenaline, and dopamine. They are highest potency, easily metabolized, but poor penetration in CNS. While the non-catecholamines like phenylephrine, ephedrine, and amphetamine, they are resistant to metabolism by COMT, that's catechol-O-methyl transfers, thereby prolonging the action. Also, they have got good lipid solubility, producing good access to the CNS. We will study few of the agonists which are adrenaline. The adrenaline are naturally occurring and direct acting. In adrenal medulla, the noradrenaline, which is released by the neurons, is converted or methylated to adrenaline. Once there is stimulation of the adrenal medulla, both adrenaline and noradrenaline are released. 80% of it is adrenaline and 20% is noradrenaline. Adrenaline acts on the receptors, which are already seen, alpha and beta. It predominantly acts on alpha 1, producing vasoconstriction, thereby increasing the blood pressure. Hence, its utilization in case of cardiac arrest or also in case of shock. Beta 1 is positive chronotroph and ionotroph, increasing the cardiac output, thereby utilization in cardiac arrest. Beta 2 action, producing bronchodilation, thereby relaxing the bronchial muscles, useful in case of asthma. So it is a drug of choice for acute asthma and type 1 hypersensitivity action or anaphylactic shock. Another is noradrenaline. It has got good potency and action of alpha receptors than beta. Alpha is responsible for vasoconstriction, and there is no compensatory vasodilatation by beta 2. Hence, it is used in case of shock because it increases both systolic as well as diastolic blood pressure. Dopamine is a very interesting, which you can understand it much better in upcoming few sessions of today. It activates both alpha, beta, dopamine 1 and dopamine 2 receptors. It raises the blood pressure. It has good effect similar to noradrenaline. But the important to remember is noradrenaline causes renal shutdown, while dopamine has got no such action on kidney, thereby protecting the kidney from renal shutdown, and hence it is a drug of choice for cardiogenic and septic shock. Beta 2 actions are useful in case of bronchodilation. During common cold, we generally use nasal decongestants. The utilization of nasal decongestant is because the alpha receptors on the blood vessels undergo constriction, thereby reducing the congestion in the nasal mucosa. Hence, the utilization of oxymetazoline. Clonidine is a presynaptic alpha-2 receptor agonist, thereby decreasing the sympathetic outflow. The analogs which acts on the receptors and not producing any action is sympatholytic antagonist. The sympatholytic antagonists are acting on the receptors, producing no effect. They are alpha blockers or beta blockers. The alpha blockers, commonly called as phenoxybenzamines, one of the example. It has got action on alpha 1 as well as alpha 2 receptors. You're already aware the alpha 1 receptor causes vasoconstriction. However, it is an irreversible one. It takes 24 hours to act. It is useful in case of pheochromocytoma, a catecholamine which is secreting tumors in adrenal medulla. Thus, sympatholytics could be used in such cases like phenoxybenzamine. Beta blockers can be selective, non-selective. The non-selective one example is propranolol, acting on beta 1 and beta 2. Beta 1 is seen in the heart, and its antagonist will bring about negative inotropic and negative chronotrophic effect. Thereby, it could be used in cases of hypertensive patient, and it is used to reduce the systolic and diastolic blood pressure. It is utilization in chronic management of stable angina. The beta 1 blockers is atenolol and metoprolol, which is acting to reduce the blood pressure, and it is very cardioselective, and has got no effects on respiratory system. So it is very important nowadays. We could use atenolol and metoprolol. The last one is the enteric nervous system. The enteric nervous system, to understand that, we have got two plexuses which are present. A plexus called as a submucosal plexus, which regulates the secretion of the glands in the mucous membrane, and the meandric plexus, which is located between the two muscle layers present in the wall. These two are very important to regulate the peristalsis. ENS can function, or enteric nervous system can function on its own. It can secrete the glands, which can control others in a paracrine manner. Sympathetic and parasympathetic also influences the activity of the GI tract. There are small neurotransmitters also present like acetylcholine, noradrenaline, dopamine, serotonin, histamine, which are present in this plexus. These are the various hormones which are other than the normal ones, which can appreciated in the gastrointestinal tract, which bring about the effect on the enteric nervous system. So with this, I'll end my session. Thank you.
Thank you, Dr. Nagaraj Pai, sir. So it gives me a great pleasure to introduce my own teacher, Dr. K. Shamkishore, sir. Sir is a professor and head of the Department of Anatomy of same institute. Sir has been a co-editor of 9th and 10th edition of Inderveer Singh's textbook of Neuroanatomy. Sir is going to speak about the happy hormones and sleep. So over to Dr. K. Shamkishore, sir. करते करते
Good morning. When we were distributing the topics, one of the topic was sleep. And nobody wanted to take that topic. So finally, I landed up with taking that topic. But then I said, there are two types of sleep, a feel good sleep and a feel bad sleep. That's why I'm going to take only the good aspect of sleep, the happy sleep. So we first speak about the feel-good hormone, serotonin. Is the original happy hormone and is essential for mood, digestion, sleep, brain function, and circadian rhythm. Since serotonin is produced by the amino acid tryptophan, a diet of fiber-rich plant foods containing tryptophan will help increasing in serotonin. One of the example is banana. That's why people say eat banana in the evening and you get a good sleep. Prebiotics are some of the foods that promote the growth of beneficial gut bacteria. This has not to be confused with probiotics that are food which contain the bacteria. Here, prebiotics only promote the growth of beneficial bacteria. This is the amino acid tryptophan. If you add a hydroxyl group, it is called 5-hydroxytryptophan. And if you remove the acid component, it will form 5-hydroxytryptamine, which is serotonin. Serotonin is a rather elusive chemical. It is involved in everything, but responsible for nothing. It's something similar to a junior staff member involved in all activities, but responsible for nothing. The other hormone is dopamine, the motivational molecule. This chemical is a part of the brain's reward system. It is what gives you pleasure sensations and keeps you from coming back for more. That's why it's involved in addiction. Besides that, dopamine is involved in motor control and cognitive function, motivation and reward system of the brain, making decision making and impulse control, memory and attention. They're all the role of dopamine. This is the amino acid phenylalanine. If you hydroxylate the phenylalanine, hydroxyphenylalanine is also tyrosine, another amino acid. Add one more hydroxyl group, you get dihydroxyphenylalanine, abbreviated as DOPA, DOPA. And when you decarboxylate the DOPA, you get what is called as dopamine. That's how dopamine is produced. Dopamine is the active neurotransmitter in addictions to alcohol, to gambling, etc. The third feel-good hormone is the endorphins, which is also called as a runner's high. Endorphins are hormones and neurosignaling molecules that function as painkillers. They inhibit the transmission of pain signals in the central nervous system by binding to opioid receptors. The ubiquitous runner's high, it can also be any exercise also, it need not be only running, is caused by a big rush of endorphins. These endogenous secreting morphine analogs are of 4 types: endorphins, dynorphins, enkephalins, and endomorphins. Out of these, only 3 are important. The first 3: endorphins, dynorphins, and enkephalins. The structure of endorphin, the beta endorphin, there are alpha and gamma varieties also, but out of them, beta endorphin is the most common. It's a 31 amino acid sequence. The gene for that is located in chromosome 2, short arm, second band, second region, third band, and third subband. Dynorphins are also dynorphin A and B. Dynorphin A is the more common one and important one. It consists of 13 amino acids. The gene is located in chromosome 20 at the terminal end of chromosome, short arm of the chromosome 20, first region, second band, second subband. And the third type, which you said is important, is enkephalin. There are 2 types of enkephalin, the metenkephalin and the leuencephalin, where the last amino acid, it's a 5 pentapeptide, it's the last amino acid when it's metenkephalin, methionine, then it's called as metenkephalin, which is located on chromosome 8, long arm, second band, third to fourth subband. Oxytocin is also called as a cuddle hormone, a neurotransmitter that helps regulate stress responses and calms the nervous system. Oxytocin helps in human bonding, generosity, establishing trust, greater perceived love. So oxytocin is also called as a love hormone. The mood, summarizing these four hormones: serotonin, dopamine, endorphins, and oxytocin. Serotonin is a mood stabilizer responsible for well-being, happiness. Dopamine is a pleasure hormone, motivational role. Endorphins is a pain relief hormone, the runner's high. Oxytocin is bonding, love, and trust. Here we see a test tube. Dopamine high is schizophrenia. Dopamine low is anxiety and Parkinson's disease. So therefore, although dopamine is a hormone of addiction, it should not be too high and it gives rise to schizophrenia. It should not be too low and it gives rise to anxiety and Parkinson's disease. It should be just at the right balance. And for the addiction component, it requires a pulse of dopamine to be released and then quickly metabolized. Whereas a sustained high level of serotonin gives rise to the happiness. Dopamine, serotonin in low quantities gives rise to depression. Serotonin, dopamine, oxytocin in high levels is responsible for happiness of love, whereas noradrenaline, adrenaline are responsible for the fright, fight, and flight reaction of autonomic nervous system. A good balance of dopamine, norepinephrine, and serotonin is required. Dopamine is a hormone of alertness in contrast to norepinephrine, which has got the primary action of concentration, and serotonin, the primary action is satisfaction. Dopamine and norepinephrine together are responsible for attention. Dopamine and serotonin are responsible for appetite. Norepinephrine and serotonin is responsible for endurance. Attention, appetite, endurance, all three put together gives rise to a balanced mood. The alertness of dopamine is responsible for clarity, motivation, and working memory. Decrease in level of dopamine gives rise to ambiguity, hyperexcitability, and passive memory. The concentration aspect of norepinephrine is responsible for certainty, determination, and recall memory, whereas reduction in norepinephrine gives rise to doubt, obsession, and dementia. The satisfaction of serotonin is responsible for relaxation, pleasure, and learning memory, whereas decrease in serotonin gives rise to insomnia, anxiety, disability, obsessive compulsive behavior, etc. We said oxytocin is a love hormone. The cuddling, snuggling, fondling, etc. increase serotonin and increase the love. When this chemistry changes to physics, it becomes euphoria. This activity during euphoria is helped by releasing endorphins, and therefore the feel-good factor, the euphoria, the painless state. The state can persist for a long time, but eventually you will reach a feeling that you feel. When you feel, you are going to feel a feeling that you have never felt before, which is called as ecstasy. It's at this point that a pulse of dopamine is released, and that's what gives rise to a person wanting to come back to more and more. Eventually, this will reach a stage of serenity, whereby the person is calm, then there are two options. Either he will proceed back to the cycle, or he will go out of the cycle and go to sleep. Sleep is a state of mind and body characterized by altered consciousness or characterized by unconsciousness from which a person can be aroused, in contrast to coma or anesthesia, where he is not easily aroused. The relatively inhibited sensory activity, but it's the same sensory activity which wakes a person from sleep. The waking a person from sleep can be a loud sound, can be very bright light, can be a sense of touch, but usually sense of smell does not wake up a person from sleep, which is why there are people who have stayed in the house which is getting burned down, and then they die in the burning itself because that smoke smell did not arouse a person from his sleep, because smell does not arouse a person from sleep. There is reduced muscle activity, especially during the period of dreaming, what is called as REM sleep, the rapid eye movement sleep. There is inhibition of nearly all voluntary muscles, almost to the state of paralysis. When the person is in a state of rest, the impulses from the surface of the scalp, you can record waves which are called as alpha waves. But when the eyes are open, the person is not awake, you get beta waves. And when the person is deep asleep, there are delta waves. So I always thought, where is the gamma waves gone? It's now found out that high impulses, extremely rapid acting, is gamma waves. This is when the brain is extremely active, great for learning, problem solving, etc. So alpha waves are 8 to 12 cycles per second, beta waves are 30 to 30, gamma waves are 31 to 120. When the person is about to sleep, stage 1, stage 2, there are theta waves secreted, which is slower cycle, higher amplitude, which is 4 to 7 cycles per second. The person is drowsing, drifting from into sleep and into dream, whereas deep asleep and non-dreaming is the delta waves, half to 3 cycles per second. Stages of sleep. Stage 1 of sleep is characterized by theta waves. It's also called as N1. Stage 2 of sleep have got sleep spindles with K complexes. These are theta waves which have got low amplitude sleep spindles with giant waves which are called K complexes. This is in N2 or stage 2 of sleep. N3 is the deepest sleep, which was originally subclassified into stage 3 and stage 4. In both cases, there are delta sleep. Interestingly, delta sleep is when we sleepwalk and sleep talk. So, somnambulism and somniloquy is most likely to occur. That's why it is said a person is fortunate when his wife and girlfriends have the same name, that when he talks in the sleep, he will only refer to the same name. Whereas there is another type of sleep which is called as REM sleep, rapid eye movement sleep, in which the sleeper's brain waves demonstrate a combination of alpha and beta that is almost similar to waking up. Here is a stage of sleep. From the awakened stage, the person is going into stage 1 of sleep. The period between awakening and stage 1 is called as sleep onset latency. Then he goes into stage 1, stage 2, stage 3, stage 4, which is called N1, N2, and stage 3 and 4 are together called as N3 because it is non-rapid eye movement. In between, after around 90 minutes or so, he comes into a short period of dream, REM sleep. And then again he goes back to sleep for a slightly similar duration, but he comes to a larger component of dream sleep. At the end of the dream sleep, you also sometimes awaken in the night and then go back to sleep, dreaming. The dream sleep duration initially is around 10 minutes. Later on, it increases. Together, it accounts for approximately 25% of the sleep. So, if you are sleeping for 8 hours, you will be dreaming for 2 hours. If you sleep for 7 hours, you will be dreaming lesser. That's why it said, dream big, achieve big, sleep well. And if you notice, towards the later part of the sleep, the slow wave sleep is not there at all. It is a little shallower sleep because you can easily be awakened from that point of time. The sleep is to maintain homeostasis. Most of the body systems are in anabolic state. Adenosine is phosphorylated to ATP, which is the energy molecule. So as the day progresses, the ATP is converted to ADP, which is then converted to AMP, and finally only adenosine. That's the time when the person has least energy and prefers to go to sleep. Sleep helps in restore the immune function, the nervous system, the skeletal muscle, the muscular system. They are vital processes that maintain mood, memory, and cognitive function. Physical rest but sleep deprivation will have an effect on body and brain. But if you just have physical rest without sleep, it does not affect exercise, it does not affect stress response. So, whereas physical activity, but sleep deprived brain does affect the mood and does affect cognitive function. So, when we say body except brain, we are also referring to spinal cord because a high transaction of the cervical spinal cord results in the lower part of the spinal cord never going to sleep. Brain requires sleep, otherwise it changes the mood and cognitive function. The sleep is produced by brain waves, brain centers. So that's why it is said that although physical rest is sufficient for the body, the function of the sleep is it's a function of the brain, by the brain, for the brain. The mechanism of sleep or circadian rhythm is entrainable endogenous biological activity that has a period of roughly 24 hours. Here, the internal time-giving mechanism is centralized by suprachiasmatic nucleus in the humans. It allows for internal physiological mechanism underlying sleep and alertness. Another chemical which is released at the time of sleep is melatonin. So the sleep neurotransmitters for the awakening state is glutamate, acetylcholine, dopamine, noradrenaline, serotonin, histamine, orexin, also called as hypocretin. For the deep sleep, it is GABA, ghrelin, adenosine, melatonin. Notice, GABA is there in both all the phases, but the activity of GABA is relatively reduced in awakening state, and the activity of glutamate, the excitatory neurotransmitter, is decreased in deep sleep. Acetylcholine comes back to the stage of dreams, where also glutamate and GABA both are there. There is glycine which is secreted during dreams. This is responsible. This is what the Renshaw cells in the spinal cord, which are inhibitory to the muscle tone and muscle activity. Talk about the key neurotransmitter which was labeled as red in the earlier one. Serotonin does not help in direct sleeping action, but it decreases the sleep onset latency. So you can quickly go to sleep during serotonin, but otherwise serotonin activity will awaken the person. Orexin is a neuropeptide that regulates arousal, wakefulness, and appetite. We said that orexin, anorexia, orexia, appetite, but is also a very important neuropeptide for arousal and wakefulness. Galanin is a peptide which modulates the action of classical neurotransmitters. It inhibits the secretion of pancreatic hormones and stimulates the release of growth hormone and prolactin. And melatonin is involved in synchronizing circadian rhythm. Melatonin is secreted when there is decreased light, and we already said glycine is responsible for the muscle atonia and muscle almost paralysis in REM type of sleep. We have already seen how serotonin is produced. When serotonin is acetylated, it gives rise to acetyl hydroxytryptamine, and then when it's methylated, you get N-acetyl 5-methoxytryptamine, which is also called as melatonin, which is why that serotonin levels are extremely high in pineal gland, which is responsible for secretion of melatonin. Melatonin is a ubiquitous molecule with natural, powerful antioxidant properties. It also exerts an anti-inflammatory effects and anti-apoptotic activities. Here is a cycle with the lower part showing midnight. You can see the sunrise in the early morning and sunset in the late evening. This cycle has been slightly tilted to the right because this is specifically meant for Mumbai, where the sun rises 1 hour later than Calcutta. Melatonin secretion starts at 9 o'clock, that is 2 to 3 hours after dark, and then it stops when there is light. The changes in the sleep are because of melatonin secretion and stopping. The deepest sleep is midway between 9 o'clock and 7 o'clock, that's around 2 o'clock or so. Peribrachial area of the pons, around the region of brachium pontis, is the one which is called as the center of REM sleep. The peribrachial area sends information to tectum, and the tectum is responsible for the rapid eye movement. How rapid is rapid? The eyes move side to side, and there are around 7 cycles which are completed in 1 minute. That means it takes around 8 seconds for the eye to complete 1 cycle, which means the eyes are not really moving as fast as it is when you are awake, but still it is much faster than when you are deep sleep. Peribrachial area also sends information to basal forebrain and thalamus, which is responsible for the cortical desynchronization. That's why the waves are alpha or beta during dreams. Peribrachial area also sends information to magnocellular nucleus of the medulla oblongata, which sends glycine to the skeletal muscle, which is responsible for the near state of paralysis and atonia in the muscle during dreams. Sleep disorders. Disease flare, pruritus, scratching, melatonin dysregulation are the two components which disturb sleep, which are treatable by exogenous melatonin. Remember, we said melatonin is anti-inflammatory, so the itching, scratching, etc., which can also be blocked by antihistaminics, but melatonin will be helpful in sleep as well. Environmental factors towards the left, what we are seeing, allergens, right, etc., disturb sleep. The dust might control in bedroom. Avoid mobile phone, laptop, desktop, and other electronic gadgets just before bedtime, and provide a dark sleeping environment, because otherwise melatonin will not be secreted. Circadian rhythm of the skin, the transepithelial water loss and the skin blood flow should be controlled by topical steroids in the evening. Cytokine dysregulation are what is seen in inflammatory, interleukin 4, gamma, 31, etc. These are responsible for disturbance of sleep. Sleep hygiene can be improved by itself exogenous melatonin, and first generation antihistaminics, benzodiazepines, and clonidine, which are all responsible for improving sleep. What will happen if there is decreased sleep? There will be memory issues, there will be trouble with thinking and concentration, there will be mood changes, and all these things will result in accidents. Besides that, deprived sleep releases ghrelin, hunger hormone, from the stomach, and decreased sleep will give us to decreased peptide YY, which is the satiety hormone. Ghrelin says, I should eat, I am hungry. And peptide YY says, hey, I am full, I have had enough to eat. But if you are sleep deprived, you tend to feel more hungry, then you go in for binge eating. And binge eating will result in weakened immunity, high blood pressure, risk for diabetes, weight gain, and risk for heart disease. Sleep disorders can be classified as dysomnias, which are either decreased sleep, insomnia, excessive sleep, hypersomnia, narcolepsy, a specialized type of disorder which results because of sleep deprivation, and excessive sleep during the day, and sleep apnea, a short breath holding spell during sleep. Parasomnias are somnambulism, walking. Sleep-related eating disorder, we said about the binge eating. Sleep enuresis, usually normal till the age of 6, but beyond that, all the first 3 parasomnias occur during deep sleep, whereas during the dreams, there is something called as REM Behavioral Disorder, which is also called as RBD. Here, the person is actually acting out his dreams. So, normally we said REM is responsible for almost muscle atonia and paralysis, but here the person is actually acting out the sleep, and sometimes there can be violent movements during this which can hurt the person himself or the bed partner. Bruxism is teeth grinding during sleep, and circadian rhythm disorders. We have heard of people like early birds who wake up in the morning and are they can concentrate and study. Where there are some people who study at night. They are called night owls. Both these are, if they are within normal limits, that's normal. But if they are excessively departed from the normal, then it's called circadian rhythm disorders. The cycle of sleep and waking is specifically by GABA. So GABA, which is shown in red color, keeps on inhibiting the ascending reticular activating system, which is shown in green color, and inhibits orexin, which is responsible for arousal. The inhibitors of arousal system includes H1 antagonists, H3 agonists, alpha-2 agonists, and muscarinic antagonists. So these are responsible for sleep, whereas potentiators of GABA inhibition, benzodiazepines, barbiturates, ethanol, chlorhydrate. These are all responsible for GABA mediated sleep. The other one is responsible for excluding GABA related sleep. Sedatives and hypnotics. Benzodiazepines are the most widely used anxiolytic and hypnotic drugs. They have largely replaced barbiturates and meprovamine, is a tranquilizer. However, benzodiazepines disturb intellectual memory, affect motor dexterity, etc. So, to avoid the side effects of barbiturate, avoid the side effects of benzodiazepine, you should take intermediate acting or short acting benzodiazepines so that you don't get sleepiness in the daytime. How do benzodiazepines help? They attach to the GABA receptors, but not at the site where GABA is attaching. When GABA gets attached, they enhance the chloride intake into the cell. So binding of GABA is enhanced by benzodiazepine, resulting in greater entry of chloride ion. Entry of chloride ion hyperpolarizes the cell, makes it difficult to depolarize, and therefore reduces the neural excitability. In contrast, barbiturates also attach to these receptors but do not require GABA. They can themselves open up the chloride channel and cause hyperpolarization. So here we have an example of drug A and drug B. If you notice, as the dose increases in drug A, the person goes from sedation to hypnosis. Hypnosis is the god of sleep. Hypnosis, anesthesia, coma, and finally it goes to respiratory paralysis and death. So if you notice drug A, if you take one tablet for sleep, hypnosis, 2 tablets you will reach into anesthesia or coma. More than 2 tablets can result in death. This is an example of barbiturate, why they are now no longer used for sleep. Yes, the ultra short acting is also still used for anesthesia, where they are properly titrated so the person does not reach the stage of coma or respiratory paralysis. In contrast, drugs B, which is shown here, at low levels causes sedation, higher levels causes hypnosis, but then as the dose increases further, they don't reach coma as fast. In fact, reaching anesthesia itself is difficult. This is an example of benzodiazepines. In fact, it is said you require around 500 tablets of benzodiazepines, where 1 tablet causes hypnosis, 2 tablets causes hypnosis, 500 tablets is required for death, which is practically impossible. But there are alternatives to benzodiazepines, antidepressants with anxiolytic effects, such as selective serotonin reuptake inhibitors. Here, serotonin is metabolized by its reuptake, but if it is not reuptaken, serotonin levels helps in facilitating the person going into sleep. First generation antihistaminics are also sedatives. The newer antihistaminics are the ones which are non-sedative. There are non-benzodiazepine hypnotics, which are not benzodiazepine structurally, molecularly, but they still act on benzodiazepine receptors. And then there is Ramelteon, which is a melatonin agonist. So they help in the additional support for person wanting to go to sleep. The point to be noted, as a sedative and anxiolytic activity, benzodiazepines are the best. But for hypnotics, we have these alternatives. CNS stimulants. So when a person is oversleeping, he requires CNS stimulants. Caffeine blocks the adenosine receptors. We said when ATP is converted to ADP, which is then converted to AMP and finally adenosine. It's adenosine which causes sleep. Caffeine blocks the adenosine receptors, so adenosine cannot act. That's why it keeps a person awake. For people who are finding it difficult to sleep, should not take caffeine after 12 noon. In low doses, nicotine, which is seen in cigarette smoke, causes CNS euphoria. But at high doses, the same nicotine blocks the receptors. So that causes depression. Or you require exogenous nicotine again further. Cocaine, the drug of abuse, blocks the reuptake of monoamines. So when monoamines are not reuptaken into the presynaptic terminus, they remain in the synaptic cleft for a longer time, which arouses the person, keeps the person awake. Amphetamine, which is the one which clearly enters the brain, releases the intracellular source of amphetamine. Amphetamine also inhibits monoamino oxidase, and therefore, and it itself acts as a weak stimulation of the nerve endings. Amphetamine is a drug of abuse. It causes a person to go into so much of euphoria, so much of happiness, so much of excitability that he cannot go to sleep. There are people, because this drug is available over the counter, people take amphetamine one day before their exams study the whole night. And they're so excited that when they have reached the exam site, they are feeling sleepy. So to counter that, they take one more amphetamine and write the paper. They're so much excited after writing the paper. But then we say, keep one more amphetamine with you because you'll require that when you're seeing your results. You have not studied, you don't remember what you have studied, you don't know what you have written. And then, of course, you'll be shocked by the amphetamines were formerly used for attention deficit hyperactive disorder and narcolepsy in individuals. But then they found out another substance called methylphenidate, which is similar to cocaine, blocks the uptake of monoamines. And because it enters the brain much more slowly, it is preferred over cocaine for attention deficit hyperactive disorder. In attention deficit children, what happens is that dopamine is not adequately stimulated, so they get bored very easily, and they therefore they are hyperactive. They can't concentrate on one thing at a time, and therefore they are poor in studies as well. So here, because of the decreasing the reuptake of mono, the dopamine remains for a slightly longer time. Attention deficit is improved, automatically the hyperactive also goes down. Modafinil, whose action is not known, is considered the first line agent for narcolepsy because of the side effects of amphetamine, which modafinil does not have. What is narcolepsy? It's characterized by difficult sustaining wakefulness, poor regulation of REM sleep, and disturbed nocturnal sleep. All patients with narcolepsy have excessive daytime sleepiness. Narcolepsy can be accompanied by sudden loss of muscle tone, cataplexy, which can be triggered by strong emotion. So you look at the hypnogram of a person who is healthy, he'll have a continuous 8 hours of sleep and rest of the time is awake. Whereas in the next lower half, you see a narcoleptic patient who is sleeping early, sleeping almost throughout the day, and in between is interrupted by REM sleep. So what happens is you might find a person who is cracking a joke, laughs at the joke, and suddenly goes into REM sleep, muscle atonia, muscle paralysis, he collapses. That is cataplexy. So narcolepsy and falling down is cataplexy. Modafinil, we said, is the first drug of choice for keeping the person awake. Selective serotonin reuptake inhibitors or serotonin norepinephrine, they also help in suppressing the REM sleep. We said serotonin norepinephrine is not secreted during REM. So that REM cataplexy is relieved by, and then there are, for the person to sleep properly during the night, you can give gamma aminobutyric acid substitutes. So stimulants to keep the person awake, serotonin or epinephrine to suppress the REM sleep, and therefore the person doesn't collapse into atonia, and GABA so that the person sleeps in the correct time. With that, we come to the end of the discussion.
Uh, Welcome our next speaker, Dr. Girish Rajadhyaksha sir, who is professor in the Department of Medicine, and he is the head of medical oncology and in charge of hypertension clinic in Topiwala National Medical College and BYL Nayar Charitable Hospital. He is the president, Maharashtra Association of Physicians, vice president of IMA Mumbai branch, honorable secretary general, Maharashtra Association of Physicians, chairperson, IMA AMS Mumbai branch. He has more than 50 publications in national and international journals, fellow of Famer, and he is a principal investigator for many of the international drug trials. I would like Rajadhyaksha sir to proceed with the session. Thank you.
It goes next. 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 So, good morning, everybody. Good morning, everybody, and thank you, Team Anatomy, for giving me this opportunity to talk to all of you this August gathering. The topic which is given to me is Parkinson's disease from the chemical neuroanatomy point of view. I don't know whether I will be able to give justice, but I will try my best. This is that great man, James Parkinson, was a member of the Royal College of Surgeons, London, and he presented his essay for the first time in 1817. And the name of the essay was Shaking Palsy. And he had presented few cases, which he then called Shaking Palsy. And later it was named after him as Parkinson's disease. What he said, he described the case as a very typical description: involuntary tremulous motion with lessened muscular power, in parts not in action and even when supported, with the propensity to bend the trunk forward and to go from walking to running pace, the senses and intellect remaining uninjured. That means the patient was having mainly or most likely to be having only motor problems. He said the senses and intellect being uninjured, but now what a broad definition of the Parkinson's disease, if you see, the intellect is also getting affected, memory and other functions are getting affected. Previously, we used to call them Parkinson plus. Now it is part of Parkinson syndrome. So remember, it's a chronic, progressive, neurodegenerative disease, and it has both motor and non-motor features. The disease has significant clinical impact on patients, family, caregiver. I had few patients in my neighborhood, I had few patients in my family, and we see, and we all have seen, how the families have got lot of problems in managing these patients. What is the prevalence? Now, we don't know the exact prevalence in India, but in USA, there are 60,000 new cases of Parkinson's disease every year, and adding to the estimated 1 to 1.5 million Americans who currently have that disease. About 18,000 Parkinson's related deaths in USA in just 1 year. While the condition usually develops after the age of 55, the disease may affect people in their 30s and 40s also. In fact, we have presented one case of young Parkinson's disease, and it is published in a reputed journal. So Parkinson's disease is a progressive neurodegenerative. So these are the degenerative diseases of the nervous system. As you know, the commonest degenerative disease of the nervous system is Alzheimer's disease. followed by Parkinson's disease. So you can say it is as common as that. Pathologically, it is characterized by continuous dopaminergic cell loss in the nigrostriatal system. I will touch upon it when we go ahead. And there's a classic triad of resting tremor, rigidity, and bradykinesia. Now, if you see physiologically, the symptoms are associated due to loss of number of neurotransmitters. And remember, the most important neurotransmitter over here is dopamine. So symptoms worsen over a period of time as more and more cells get degenerated. And the course of the disease is variable. Some patients have very slow, relentless course, whereas in some cases, the progress is quite rapid. So decrease of dopamine content in the substantia nigra. Okay, this is the part of the midbrain, okay, which disrupts the delicate balance between neurotransmitters. There are various neurotransmitters, and this causes variety of neurotransmission changes that eventually influence the motor cortex, and as a result affect movement control and autonomic functions as well. So most important, as I told you, is dopamine. Now, movement control is accompanied by complex interactions. Remember, whenever we are doing various actions or various motor movements, okay, for example, I am lifting my pen or I'm writing something, so this movement control is very important. And that is accomplished by complex interactions among various group of nerve cells which control your muscles. One such important group of neurons is located in the substantia nigra, which is there in the ventral part of the midbrain. So nigral neurons give rise to extensive network of axonal processes that innervate the basal ganglia. So there is a connection between midbrain and basal ganglia. Neurons of the substantia nigra communicate with the neurons of the basal ganglia by liberating neurotransmitter dopamine. So suppose I want to communicate with you, what I will do, I will pick up my mobile phone and I will call you. That is one way of communicating. Other is I will send you the message which is called SMS. Third is I can send on my WhatsApp. Fourth is I can email you. So there are various ways by which I can communicate with, or I will come to your place and I will straight away talk to you. So these are the various ways I can communicate with you or some other person. Similarly, when the neurons have to communicate with each other, they release neurotransmitters, and there are multiple neurotransmitters which are there in our nervous system. So these neurons, they communicate via dopamine. So dopamine becomes a very, very important neurotransmitter in this particular system of neurons. And such an interaction at the biochemical level is responsible for fine-tuning of any organism's movement. So whichever when we do the movement will become smooth, movement will become precise, and movement will become adequately powerful. So these three components of any motor action will depend on the proper balance of various neurotransmitters in that particular neuronal system. Now, if you see this particular diagram, I did not tell you because you know much more than me as far as neuroanatomy is concerned. But remember what we see, we are the clinicians, and this is the red nucleus. This is a cut section of the midbrain, and this is that black substance. Black substance, because we are medicos, we use a fancy language, so we say substantia nigra. But basically, it's a black substance. It is here, and if you see as the Parkinson develops and progresses, this black portion is disappearing. Okay. So this is called degeneration of this particular thing, and we see the ventral portion of the brain. We see it looks like this, and these are the various neurons, and they are dendrites and their axons, and these are the axons which are having communication with other neurons. And when they communicate with each other, see they release into what is called synapse. So synapse, as you know, is a gap between the two neurons. So there is a receptor, and here the neurotransmitter molecule, whichever it is. So the neurotransmitter molecules are released like this, the synapse. In this particular system, the main thing is dopamine. So in Parkinson's disease, the neurons of substantia nigra progressively degenerate. Now, why they degenerate? We used to say during our days when we were the students, we used to say GOK. Our teachers say GOK means God only knows. Means we don't know. Now we know there are so many things which are there. Some, and as we know, most of the answers are lying in your own genes. So there are many genetic factors which are there because of which this is happening. But this is not the topic of today's discussion. It's absolutely complex but very, very interesting topic. As a result, the amount of dopamine available for neurotransmission in the corpus striatum is lower. So this corpus striatum, you know, the globus pallidus, putamen, the caudate nucleus and all. So these are basal ganglia, what we call. So this particular neurotransmission in corpus striatum is lowered. So we call these a nigrostriate fibers, going from substantia nigra to corpus striatum. So corpus is a nigrostriate fibers. Similarly, there is a structure which is called thalamus, which you all know. So this thalamus also, if you see, sends the has the communication with this corpus striatum, and we call them thalamostriate fibers. So we have nigrostriate fibers, we have got thalamostriate fibers, and they are using various messenger systems. So biochemical imbalance manifests with typical clinical symptoms that include resting tremor, rigidity, bradykinesia, loss of postural reflexes. So overall, the balance and motor coordination becomes poor. We'll see how it happens. So remember, this is a dopamine level in the normal. See how the normal neuron releases this dopamine and there is a normal movement occurs. Whereas here, if you see the Parkinson's patient, the neuron is affected and the dopamine release is very, very poor. And therefore, that leads to what movement disorder, which we see in the typical case of Parkinson's. So remember, in recently, if you see, the Parkinson's is increasingly seen as a complex neurodegenerative disease with a sequence of progression. There is a strong evidence that it first affects dorsal motor nucleus of the vagus nerve, okay, and olfactory bulb and nucleus. And therefore, if you see, the smell sensation is also affected, and in fact, smell sensation affection is one of the early manifestations, which is many times it is missed. And then the locus coeruleus and eventually substantia nigra. Okay, cortical areas of the brain are affected at a later stage, and when they are affected, then even your higher functions, memory, and all will start getting impaired. So damage to this various neuronal system accounts for the multifaceted pathophysiologic changes that cause impairments not just to the motor system, but also to the cognitive and neuropsychological systems. And therefore, if you have a full-blown case of Parkinson's disease, it not only has the motor problems, but it also has neuropsychological manifestations and cognitive manifestations as well. So what is the role of dopamine? See, dopamine, like other neurotransmitters, transmits the chemical messages from one node to another across the synapse. Okay, now dopamine is secreted in the synapse from this membrane which I showed you, and within the synapse, dopamine can be broken down, okay, and rendered inactive by two enzymes. One, you know, is monoamino oxidase, and other is COMT, that is catecholamine methyltransferase. So COMT and MAO. So these are the two enzymes which inactivate them very rapidly. One therapeutic strategy, therefore, is to use MAO inhibitor or COMT inhibitor, so that the dopamine, suppose it is in less quantity, but if it remains for a little longer time, it may serve the purpose. So that is a principle behind using these kind of drugs. So progressive loss of dopamine inputs in Parkinson's disease leads to imbalance in the coordinated signaling of dopamine and acetylcholine in the striatum. As I told you, there are nigrostriate fibers and there are thalamostriate fibers. And these thalamostriate fibers which are there, okay, they are cholinergic. So that means they send their message or they transmit through neurotransmitters called acetylcholine. So these are cholinergic. Now what happens, because dopamine is less? See, it is not that the acetylcholine level is increased, but acetylcholine level is same. But because dopamine is less, there is an imbalance between acetylcholine and dopamine in the corpus striatum. And this is the corpus striatum is your extrapyramidal headquarters. And all the movements are controlled by this extrapyramidal system. And therefore, you will get the problems. Okay. So neurotransmitter imbalance is very important. Movement control, as I already told you, I will not spend time. And see, this particular diagram shows normally with normal aging, if you see this green line, slowly the dopamine depletion occurs as you age. This you can from the birth to say about 80 years of age. But if you get the idiopathic Parkinson's disease, it will come down more rapidly. And if you have got certain genetic factors which can also cause this particular problem, and there is one entity which I told you in the beginning, early onset, it develops in your 30s and 40s, then it comes down very, very rapidly, this red lines. Okay, so this graph shows how it normally, so normally also some people will get some mild features of Parkinson if they live beyond 80 years of age. And this is that particular diagram which I wanted to do. This is a nigrostriate pathway, and this is a caudate nucleus and putamen, which we call corpus striatum, and this is the midbrain where we have substantia nigra. So these are these nigrostriatal neurons, okay, which are having the problem because of degeneration. This I need not speak, but remember these neurodegenerative disorders like Alzheimer's, frontotemporal degeneration, and Huntington's chorea, etc., motor neuron disease, they are increasingly being realized to have common cellular and molecular mechanisms, which was not known about 20 years back. Okay, so this is realized in last 10 to 15 years. So there is a protein aggregation and inclusion body, we know Levy bodies and all. So these are deposited in certain areas of nervous system, and that will lead to onset of degeneration. You know this person, the very, very famous personality, and how he developed Parkinsonism, I would say. Remember, Parkinson's disease and Parkinsonism is not the same. So Parkinson's disease is this idiopathic Parkinson's disease, which I told you it could be because of nervous genetic problem or some of the other problems. We don't know the exact cause, but there are certain causes which can lead to Parkinson-like syndrome, and that is called Parkinsonism. So this person, a very famous personality, Mr. Muhammad Ali, the great boxer world has ever seen, he, because of repeated injuries to his head, there's a part of his occupation, that boxing, and he got injured a lot of times because once you hit on the head, you can get knockout, and therefore they always try to hit on the head, any part of the head, and therefore he got multiple hits on his head, and that led to his post-traumatic Parkinsonism. But this is not our Parkinson's disease. Here the mechanism may be different. So what is Parkinsonism versus Parkinson's disease? So Parkinsonism, which is also known as atypical Parkinson's or secondary Parkinson's, or it's a neurologic syndrome. So you have tremor, rigidity, bradykinesia, etc., etc., but the cause is different. So these patients typically respond poorly to pharmacological intervention. That we have to remember, because here the mechanism is not the thing which I described in the beginning. So Parkinson's often has an identifiable cause. What is like exposure to various toxins, then methamphetamine, trauma like this boxing and all, multiple strokes. So it's a vascular type, like vascular dementia I have in comparison with Alzheimer's disease. Similarly, you can have vascular Parkinsonism and other nervous system disorders and illnesses and certain infections. And typical Levy bodies are, which are seen in Parkinson's disease, are not seen in these other causes of Parkinsonism. So it is also associated with disorders such as progressive supranuclear palsy and all. So you have vascular Parkinsonism, drug-induced Parkinsonism, the neuroleptic drugs like reserpine, antipsychotics like haloperidol, metoclopramide. So various these drugs, if you're taken for a long time, they can cause Parkinsonism, but not Parkinson's disease, remember. So exposure to certain toxin, severe carbon monoxide poisoning, mercury poisoning also can lead to Parkinsonism. So this also we have to remember. So history is very important when you are dealing with a patient with Parkinson's syndrome. So patient will come with features. Patient will not say that I have got Parkinson's disease or some other cause. So to take proper history and find out. So these are various scans which are available. And these scans, if you see, this fluorodopa scan, I will tell you, this is the, if you see on the left side, I said normal substantia nigra, you see here. And if you see on this side of the Parkinson's disease, there is a degeneration. So it can be very well detected by this particular test. So there are various non-invasive investigations like PET scan, fluorodopa scan, etc., which are available today, but we don't do this to make the diagnosis. Basically, the diagnosis is clinical. And this is the way we stage it. One is only unilateral involvement, 1.5 unilateral and axial. So trunk is also involved. 2 is bilateral without impairment of balance. 2.5 is mild bilateral disease with recovery. 3 is mild to moderate bilateral disease, subpostural instability, but physically patient is independent, not dependent on anybody. Then you get severe disability, that is 4, but still patient is able to walk and stand unassisted. and last is the confined to bed or wheelchair. These are the classic cardinal motor features. Okay, bradykinesia, rigidity, and tremors. So what they say, basically, what is the imbalance? The imbalance is dopamine lack and acetylcholine preponderance. And because of this, if you see, the lack of dopamine will lead to the most important manifestation, that is akinesia or bradykinesia. That is basically slowness of movement. It's seen in about 80 to 90% of patients. Without bradykinesia, it is very difficult to make the diagnosis of Parkinson's disease. Decrease amplitude of the movement. So you see, normally when you walk, there is a swing of your arms. Okay, so this hands, they will walk like a stiff hands. So they will not walk with normal swing of your arms. Rigidity is very important. Again, it is mainly seen in shoulder and arm muscles. Resistance to passive movement is there, and what we typically call, because it is associated with tremors, it's a cogwheel type of movement which we see in our wrist. And then, of course, the tremors at rest. Okay, so common initial symptom, usually these patients start with unilateral tremors of one hand, okay, fingers and all. And these are typically pill rolling type of movements, primarily distal, involve hand, and then may involve jaw, tongue, lips, chin, or even legs. So this is a typical patient of a patient has a mask-like face. Why? Because there's an expressionless face, there's a rigidity of the facial muscle also, and therefore the patient cannot remember. A few years back, means about 10-15 years back, it was detected, diagnosed in great actor like Amitabh Bachchan. Now, Amitabh Bachchan is such a fantastic actor that there are many actors now in Hindi movies. Even if they develop Parkinson's and mask face and all, we will not understand only because they don't act. They just dance and they do something. But people like Amitabh Bachchan were very fine actors, and they show that, like Nasiruddin Shah, these people, Om Puri and all. So when they get Parkinson's disease, their mask-like face immediately picked up because their facial expressions are affected. Rigidity is there, forward tilt. So as James Parkinson described, the propensity to bend the trunk forward and to go from walking to running phase, a typical Festinian gait is there. Okay, so they walk as if they are chasing his own center of gravity. So we may feel that this old man or old woman may fall down, but usually they don't fall down because cerebellum is not that much affected. Okay, and your dorsal column fibers are also not that much affected, and therefore they don't fall down. But they have the propensity to bend trunk forward and go from walking to running phase. So that is very, very typical gait. Once you see a Parkinson person walking, you won't forget it. Similarly, their speech also, if you see, they either start with a big then they become very slow, or they start very slow and then suddenly they. So this is a typical Parkinson speech. So the various motor activities like gait, then movements, then speech, various things get affected. Of course, your handwriting will be affected because you won't be able to hold a pen or pencil in your hand properly, and your handwriting will deteriorate. So how you diagnose? Diagnose primarily clinical. So I told you PET scan, this scan, that scan, but primarily it's a clinical diagnosis. And conventional method means 2 of the 3 primary symptoms should be present. I told you 3: akinesia, rigidity, tremor. At least 2 of the 3 should be present. Absence of other neurological signs upon examination. No history of other possible causes, which I told you various causes, and responsive to Parkinson's medication. The most important being levodopa. Remember, this is a tug of war. The tug of war between acetylcholinergic versus dopaminergic, and therefore the principle of therapy should be to increase dopamine or to reduce acetylcholine. So that is a principle. Once you understood, my lecture is very easy. These are the medications: carbidopa levodopa combination, dopamine agonist, MAO inhibitor, COMT inhibitors, anticholinergics, amantadine is also there in the early stages. Surgical, there are many things which are now going out, but still there is a deep brain stimulation for those who are in the advanced stages, not responding to medical treatment. So carbidopa, levodopa, remember, since levodopa is the most effective treatment, but it is having a lot of side effects, remember, and therefore we have to keep it for the advanced cases as far as possible. Now levodopa, if you give, it has a potential to increase the brain dopamine level, but it gets destroyed peripherally, and therefore it is combined with carbidopa. Okay, like in female, that like in Hindi movies, the heroine is very rich, and the father of the heroine is very much suspicious that she may go away with some poor boy, some mechanic or somebody, and therefore he always keeps bodybuilder, okay, who will protect her all the time. Now, what will happen? Similarly, carbidopa is given so that it will prevent the destruction of levodopa peripherally, and so that the levodopa enters the blood-brain barrier smoothly where it has to act. So till the time, and carbidopa का क्या होता है कि carbidopa cannot enter blood-brain barrier. So carbidopa will not be allowed inside the blood-brain barrier, and therefore levodopa will go into the brain and it will act where it has to act. Remember, but it has side effects like nausea. It can cause hypotension also. Then you have got anticholinergics to restore the balance. So you have to give anticholinergic also. You have got benzotropine, piperidine, diphenylhydramine, so many. Okay, and we have used it also. You know, Pacitane and all. If you remember, during our days, hardly anything. Levodopa and Pacitane. Then came amantadine and some other drugs. So amantadine basically developed as an antiviral drug for influenza, but then it was found to be effective in the early stages of Parkinson's as well. So typically anticholinergic drugs have greater role in tremor predominantly, because I told you akinesia is because of dopamine lag, and rigidity and tremors, these are positive symptoms. So negative symptoms because of lag, positive symptom because of preponderance of choline, acetylcholine, and therefore for tremor predominant Parkinson's disease, no, in any patient something may be more prominent. So those your tremor is more predominant or rigidity is more predominant, you can give anticholinergics in these patients. CONT inhibitors also there, so tolcapone and all, but you know, they have the effect of as I told you, it inhibits this, and therefore the dopamine will remain in the synapse for some more time, and it can do the job. Remember, it requires close liver function monitoring, okay, because it is associated with, sometimes not common, it's very rare, it can cause potentially fatal hepatotoxicity. Then the group is dopamine agonists. Okay, they directly stimulate dopamine receptor. That means they mimic the role of chemical messages. So the receptor will feel as if dopamine only has come. That is not dopamine, but it is a look-alike. And these are bromocriptine and all we have used, and there are many others like propinerol, which is now available. Alone or combined with levodopa, they are effective against early Parkinson's disease. Remember, there is one drug called apomorphine, which is given parenterally. And this is a powerful dopamine agonist. It is not weak, it is very powerful. And therefore, it is used when in certain emergency situation. What happens? We see what is called on-off phenomenon. In Parkinson, once you start on treatment, you can have on-off phenomena. What is on-off phenomena is? On means the patient's dose is adequate and patient is feeling very good. Patient is not having much symptoms. That's on. The off means suddenly the patient feels that his symptoms have worsened. And this can happen very rapidly and very severely. In that case, you can give parenteral apomorphine, and which is very useful. Then MAO-B inhibitors in the brain, again, as I told you, they play important role in breakdown of dopamine. Okay, you have selegiline, which is there for quite some time now, and now the newer drug which has come is rasagiline. Useful in symptomatic control of Parkinson's disease, especially mild to moderate cases, and of course as adjuvant therapy for patients with Parkinson's disease and motor fluctuations. Amantadine, as I told you, is a dopamine agonist, and it is used for mild Parkinson's disease in the early stages. Okay. Remember, live influenza vaccine, because now we are dealing with influenza vaccine and COVID vaccine and all. So live influenza vaccine should not be given the patient while patient is on amantadine, because that vaccine will become useless. And lastly, I told you the deep brain stimulation also is there. I will not go into the details because of time constraint, but this is a very new technique and it is really giving good benefit. This is the, again, if you see the thalamus is there, okay, and this is globus pallidus and Glutamate and all these things, So you have this substantia nigra. So this part or pars compacta, which is important in production of dopamine, and this part is a pars reticulata, which is GABA, which uses GABA as the neurotransmitter. This is very interesting concept of deep brain stimulation, and those patients who are advanced cases and those who can afford and the facilities are there, they can do this particular modality of therapy. So if you come to the summary of the treatment in the initial stages, remember, when choosing the medication, the individual approach is required based on symptoms and preference. What is predominantly the major symptom of that particular patient? Start low and go slow is very important. Start low in small dose, especially with levodopa. Don't start high dose. Very, very small dose, because otherwise the patient will give a lot of side effects. Remember, that is very important. Then medications with more continuous stimulation profiles, such as dopamine agonists, or MAO inhibitors, are preferred in initial stages if appropriate for the clinical profile of the patient. Levodopa, remember, should not be avoided at any cost, even in initial stages. Remember, levodopa is the best treatment as far as medication is concerned. Consider levodopa if other medications are not indicated or they are not effective. And this is a flow chart which shows that at any age, depending on how much is the functional impairment, I gave you the stages 1, 2, 3, 4, 5. Accordingly, you can select either no treatment or only salicylic, which we give, but in the Western people, they give more of rasagiline for little more advantages. And if it is moderate functional impairment, you go by age. The patient is less than 65 or more than 65. And depending on various risks, you can give low dose dopamine agonist, rasagiline. And later, of course, you will have to start with low dose of levodopa also, with or without other COMT inhibitors or MAO inhibitors. So this flow chart will be really very useful for those who are treating the patients of Parkinson's disease. I am telling Parkinson's disease, I am not touching upon Parkinsonism secondary causes. So in summary, while other dopamine agonists are successful at controlling symptoms of Parkinson's disease early, after the onset, the L-Dopa is the most effective pharmaceutical therapy at helping to improve quality of life. Because remember, in these patients, the quality of life is going to be very, very important, especially once symptoms become more unmanageable with other antidepressant medicines. So that you have to remember. There is no known cure for Parkinson's disease, but alternative drugs, surgical and behavioral therapies exist for the treatment of Parkinson's disease. And so basically it's a multidisciplinary therapy. Our speech therapists, physiotherapists, occupational therapists, psychologists, psychiatrists, all these people are very important in managing these patients very nicely. So there is no known cure for Parkinson's disease, but these alternative drugs, surgical, behavioral therapies exist for treatment of Parkinson's disease, and new therapies are being developed to help mitigate the side effects and symptoms of the progressive disease. So physical therapy, occupational therapy, speech therapy, they are very good non-drug alternatives. So with this, I thank you so much for patience. Thank you.
Thank you, Rajadhyaksha sir, for giving such a wonderful knowledge to us. So there is one announcement. There will be a break for 1 hour from 12 to 1 p.m. So be available sharp at 1 p.m. We are going to start the next session. There will be a lunch break for 1 hour. Okay, so come back sharp at 1 p.m. Thank you. Good afternoon all. Welcome you all back to the second session of this webinar. So we are going to start the second half part of this session, this webinar here. The first speaker of the this session is the Dr. Adnan Kadiali. Okay, I would like to invite him to in the first session here. Dr. Adnani has completed his MBBS from the Government Medical College, Dhule. Okay. Dr. Adnan has done his MD Psychiatry from Diva Patil Medical College, Hospital Research Center, Pune. Sir has a vast experience in his field of specialty. Sir has published many research papers, and so over to Dr. Adnan. Thank you, sir.
Thank you so much, ma'am. Let's start with the presentation. The biggest challenge which I had when I was making this PPT was कि खाने के बाद how do I increase or decrease the dopamine in your mesolimbic pathway, which must have increased after all the sugary food you must have eaten. And after decreasing the dopamine, how do I increase a little bit of norepinephrine, which increases the blood vessels and alertness in your brain, and then increase the acetylcholine and the glutamate, which stimulates learning and memory. So that to me is the biggest challenge. And one solution I thought was, why not I go about the etiopathogenesis in a sequence way in the form of a story on how it has evolved. Now this has two benefits. One is hopefully it's interesting. And secondly, if we know how we got to where we are, we will be able to figure out where to go next. So at least that is what my aim is. So with that, let me start with my presentation. Okay, so we are going to discuss the neurochemistry of Alzheimer's. Yes, the etiopathogenesis of Alzheimer's is a very, very vast topic, but I'm going to discuss most of it in a sequence, in a story way, with more emphasis on the chemistry part of it. All right, so this is where it all started. These slides were where it all began. In 1907, there was this German psychiatrist who, I guess probably because of the skeptics of those age, wanted to figure out the neurological basis of all psychiatric disorders. So what he did was, a 51-year-old female with delusions, hallucinations, and progressive memory loss, he chopped off her head. After she died, I mean, these psychiatrists are a little quirky, but not that quirky. So after she died, he chopped off his head, and he did a very simple microscope analysis with stains, which was available in the 1970s. So what he found were two very specific abnormalities. The first one was intracellular, and the second one was extracellular. These two particular abnormalities still form the basis of every etiopathogenesis of Alzheimer's we know at this point. And no points for guessing who that German psychiatrist was. His name was Mr. Alois Alzheimer's. So once he did this simple microscope analysis and he figured an extracellular accumulation and an intracellular accumulation, we moved on to a more sophisticated electron microscope analysis. Things advanced. So in the electron microscope analysis, the intracellular segment, actually we realize that these are filaments which are tangled with each other, which no surprises for guessing, it's called tangles. And the extracellular mass is a very amorphous eosinophilic mass, which also has protein filaments at its core. Those protein filaments were then named amyloid. So after electron microscope, after that era went away, we realized that our neurons talk to each other with synapses. And they talk to each other through the synapses via neurotransmitters. So this was the age of neurotransmitters, you know, the 30s, the 40s, where we realized that there was acetylcholine, GABA, glutamate all throughout the brain. During that time, we also realized that learning or memory mein na acetylcholine ka bahut bada. So once we realized that, we thought, okay, if acetylcholine is learning and memory, maybe in Alzheimer's, that can be implicated. So what we did is we tried and studied, we were trying to study the acetylcholine receptor in the brain. So what we tried to analyze is the acetylcholine it secretes. Now the problem is, after a person dies, the acetylcholine gets eaten up by the acetylcholine esterase. So there is not much acetylcholine left to study. So instead of studying acetylcholine directly, we tried to study acetylcholine markers. So one was CCHAT, which is acetylcholine transferase, which is used in synthesis of acetylcholine. And the second was acetylcholine esterase, which was used in acetylcholine degeneration. Now the logic behind that is, agar ye dono zyada hai to acetylcholine bhi zyada hai. If both of these are less, means acetylcholine is also less. So we did a post-mortem analysis of these two markers in Alzheimer's patients. So what we found is, as compared to control loop, different areas of the brain had a decrease in acetylcholine esterase also and acetylcholine transferase also. And this study, a Lancet study, was replicated in many different studies during that time. So it became very clear that acetylcholine neurons get affected, they die, which leads to decrease in acetylcholine in Alzheimer patients. So this at that time was very, very clear. So then arises our next question. Okay, does it decrease in just one area of the brain, entire brain, specific areas more than the other? So each area of the brain was then specifically studied. We at this point realized that it's not uniform. Sare brain mein acetylcholine decreases, but it's actually the hippocampus and the anterior cingulate where the percentage of acetylcholine decrease is much, much more. So we realized that the acetylcholine neurons die in Alzheimer's, but they die more in the hippocampus and the anterior cingulate, which makes sense because the memory region implicated was actually the hippocampus at that point. So these findings then made sense. We then went on to study this even further, and we realized it's not just the levels. Depending on the severity of dementia, the cholinergic neurons died more. So if there's somebody who is died with more dementia or very severe dementia, there were less cholinergic neurons. If someone died with mild dementia, there were a little more cholinergic neurons. We were also able to understand that in the hippocampus, the loss of these cholinergic neurons were not all together. Sab kuch ek saath mein nahi hota. They used to start in phases. So first, the transenteral region was affected. After that, a little more of that region. Then a little more, then stage 4, and then stage 5, where the entire hippocampus. And this staging was also clinically correlated. So we understood that in Alzheimer's, hippocampus gets affected first, and the cholinergic neurons, which have acetylcholine, they die first. Now, obviously, acetylcholine was studied. So why should the other neurotransmitters be left behind? So we studied glutamate also at that time. We also realized that the glutamate was also less. So the neurons which had glutamate also decreased in the entire brain all throughout the brain. But this was a little different than acetylcholine. What we realized, that glutamates don't die because the glutamate is less. The neurons die because their NMDA receptors get overactive. Imagining something dying because of overwork. I'm sure we all doctors agree that overwork can be harmful for us. So yeah, NMDA receptors, they get overworked and they die according to the research at that. Now, what prevents the NMDA receptors from getting overworked? It is actually the magnesium which is attached to it. Now I'm going to come back to this magnesium which prevents the NMDA receptors from getting overworked at a little later stage. But for now, just know that the glutamate receptors also used to die, and they used to die because the magnesium of the NMDA receptors used to go away, and NMDA receptors used to get overactive, which used to kill the glutamate neurons, and glutamate also used to decrease in the brain. So of course, if glutamate used to decrease, acetylcholine used to decrease, other receptors are also implicated. So of course, other receptors will miss out. But the thing is, the studies of GABA, dopamine, serotonin, and norepinephrine were a little conflicting. We weren't very sure whether they are affected or not affected, even at this point. What we know for sure is they get affected probably at a later stage, but probably not at the early stage of Alzheimer's. So the drugs, this is all the 1960s, 70s. So of course we know acetylcholine receptors ja rahe. So drugs pe kya karne ka? Give drugs which increase acetylcholine. So we invented dopamine, galantamine, and rivastigmine, which increase the acetylcholine and which help Alzheimer's to some degree. Now, this concept is very important because it's something I want to make you understand. So let's say there's a patient with lung damage and his lung is slowly deteriorating and dying. You can give oxygen, you can give good amount of oxygen. What will happen? He will improve for some time because जो बचे हुए हैं वो oxygen ज़्यादा लेगा, लेकिन the lungs are dying. So you're not really curing the problem. You're just helping him to survive for a little longer period by giving him more oxygen. But the lungs are dying. You have yet not found out the cause for why the lungs are dying. Similarly, acetylcholine neurons are going away. They are decreasing. By increasing acetylcholine, by giving donepezil, galantamine, and rivastigmine, what really we are doing is just increasing, but we're not really preventing the neurons from dying. So Alzheimer's still happens, but symptomatically the progression, it decreases to some extent. Similarly with memantine, which is an NMDA antagonist. Over here also we are able to stop or block the NMDA receptors, but it is only temporary because the neurons die because you've not found out the cause for neurons dying. So at this point, during the 1960s and all, we know what causes Alzheimer's. The destruction of neurons, which are primarily acetylcholine and glutamate. We want to know the how and the why. So to figure out the how and the why, we did more research. So what we realized, the places where these neurons die, over there is actually more of those amyloid plaques, which I talked about before. Well, more of that is found in the same place. Also, remember I spoke about the magnesium going away, which increases the NMDA receptors, which cause more death. Well, guess who takes the magnesium away? It's the amyloid deposits. So now to figure out why these neurons die, we go back to the amyloid deposits, which were first discovered in 1907. Those studies led us to understand. So at this point, our neurochemistry understanding was much more nuanced. We had more sophisticated neurochemical techniques to find out the specific proteins and the genes involved in that. So at this point, we were able to understand that those proteins in the plaque was actually beta amyloid proteins, and the tangles were actually hyperphosphated tau tangles, which is also, of course, it is these two which lead to neurodegeneration, dysfunction and loss to synapses, which decreases the circuit, which causes dementia, and it causes death. So now we know that these proteins, which are beta amyloid and the tau hyperphosphorylated proteins, are what causes the destruction. And there are specific genes, which I will not get into at this point of time, because that will require a complete different lecture, which lead to the abnormal beta amyloid. What do I mean by the abnormal beta amyloid protein? That is something neurochemistry has taught us. So see, what happens in a normal person is the amyloid beta protein, which is the jud of all the problems. This is actually inside a precursor, which is actually a part of a precursor protein called amyloid precursor protein. And this is actually embedded in a normal person. And alpha secretase enzymes, it acts at the APP protein and it splices it. It splices it into three parts. One part is in the middle of the amyloid beta protein, so that the amyloid beta protein itself is divided into two parts. And these three parts get degraded by the cell. Now, what happens in a mutated Alzheimer patients? Instead of alpha secretase, there is beta secretase. This does not break the amyloid beta protein. This splices the APP at a place which is a little before. So the three parts which are formed has a completely intact beta protein. And this intact beta protein goes further, gets oligomerized, causes plaques, neurotoxicity, and neurodegeneration. It gets phosphorylized, which phosphorylizes the tau proteins, which cause neurofibrillary tangles, leads to neurodegeneration and neuron loss. So this is actually how the neurons get used. All right. So this is now we come to 1970s, 1980s, where all of these findings were happening. This is where study and neurological study as a whole takes a very, very major change. Where every study used to be after a patient is dead. For the first time, we were able to study a patient while they were alive with the invent of the MRI machine. It is the MRI machine which then changed the chemical analysis also. After the invent of the MRI machine, no, we could actually study the chemicals while the patient is alive. And that is the MR spectroscopy. So what we were now able to do in an MR spectroscopy is we do not have to wait कि वो मरेगा, Alzheimer's होगा, मलेगा, फिर हम brain को काटेंगे, देखेंगे. While he is alive, we are able to study the different levels of the different chemicals in that place. So you see these peaks over here. Every single chemical has a different peak ratio, which is seen in the MR spectroscopy. And we're able to differentiate a normal enzyme level from an abnormal enzyme level by studying these different peaks. So NAA is N-acetyl aspartate, Cl-chlorine, taurine, and creatine. This is a normal patient without Alzheimer's, and this is, a control, and this is somebody who is suffering for Alzheimer's disease. So what we found characteristically is the N-acetyl aspartate levels, the peak is less, and the myoinositol, the MI peak is more. So now, even in a live patient, we are able to tell that this patient probably could have Alzheimer's or probably does not have Alzheimer's. And of course, we took the study even further. Now, this study, which is actually very recently done, told us that this is a patient who has no symptoms of Alzheimer's. This is a patient who has Alzheimer's, and this is the patient who has symptoms of Alzheimer's, maybe even very mild, which we have not yet clinically diagnosed. So clinical diagnosis of Alzheimer's is not yet done. This patient still suffers from what we call MCI. And we have realized that the levels of NAA is different from that of Alzheimer's and that of normal patients. What does this mean clinically? This means that even before somebody develops Alzheimer's, even before we see the symptoms of Alzheimer's, we are able to tell that this person might go on to develop Alzheimer's very soon probably and detect mild cognitive impairment, which will help us treat the person better and increase the lifespan of this patient. By new MR spectroscopy. Also by MR spectroscopy, we can actually use it as a biomarker where the NAA decrease, the N-acetyl aspartate decrease will lead to neuron loss and damage. The creatinine increase, which is a sign of decreased energy metabolism. The MI increase, which is a sign of glial cell damage. And the CHO increase, which is a sign of age spots in the brain. If these things happen, and if the NAA-CR ratio decreases, and if the MI-CR ratio in the brain increases, especially in the hippocampus, we can probably safely say that this person has Alzheimer's, is suffering from Alzheimer's disease. This, along with PET scans, which show us the plaques and the neurofibrillary tangles, help us now diagnose Alzheimer's at a very, very early age and we can treat it at a very early age to prevent deterioration. This is what I wanted to speak about. I am sure you have understood something. Thank you so much. Any questions can be on the chat, please. All right, I will then take it.
Dr. Adnan. Proceed to the next lecture in the webinar. It's a pride to introduce our next speaker, Dr. Sachin Baliga, who has completed his MBBS and MD in psychiatry from Topiwala National Medical College and our hospital itself. He holds a degree of DNB and completed his fellowship in non-invasive brain stimulation of psychiatric disorder from NIMHANS. Currently, he is working as assistant professor in Department of Psychiatry in Nair Hospital. He has many publications and awards to his credit. I request Dr. Sachin to start with this session.
A very good afternoon to everyone. After this marathon session that was taken by my colleague Dr. Adnan, we now move on to the next session in this series of presentations related to clinical neuroanatomy. The current session will be on clinical neuroanatomy of depression. Before I begin, I would like to just highlight on a topic which I think even Adnan must have spoken about, is that when you talk of anything related to the brain, it becomes extremely reductionistic or simplistic if you try to break it down to a couple of neurotransmitters or enzymes. Every illness related to the brain, as is true for many other things in the body in general as well, is an extremely complex outcome of a variety of factors. So that is why what I felt was that for this current session on neuroanatomy of depression, I would like to highlight on different aspects which come together to give rise to this complex mood-related syndrome. So the scope of this session or the flow of this session will involve introduction to depression, followed by relevant neurobiological structures, changes that happen in depression. Then I'll be touching on chemical neuroanatomy associated with the role of stress, immunological mechanisms, touch on a bit of genetics just to complete the entire view, followed by the actual neurochemical and hormonal changes in depression. And then we will try to integrate all these varieties of evidences that we have seen. And at the end, I'll be placing some summary points in front of you. So talking about depression, as we know, psychiatric illnesses are considered as syndromes due to lack of proper biological markers. So even depression is a neurobiological syndrome, which is characterized by pervasive sadness of mood, a prominent loss of interest in activities or anhedonia, changes in sleep and appetite, generally a reduction in either of them. However, there can also be an increase in sleep or appetite, reduction in the energy levels, lack of self-esteem, and in general, very bleak thoughts about the future, which can also lead to suicidal thoughts, or attempted or completed suicides. If you look at the prevalence, it's an extremely prevalent illness with a lifetime risk of 20%, which is pretty high. And you can see that in general, individuals who experience an episode of depression, out of these, 3/4 of these patients experience more than one episode, usually 3 or even more, and the risk is higher with each episode. So for each episode which is untreated, there is a chance that the patient will have more and more episodes, and the chance just goes on increasing. So when we look at the etiology of depression, it's a very multifactorial phenomenon which includes trauma, be it physical or stress-related psychological trauma, endocrine-related conditions such as hypothyroidism, diabetes mellitus, Cushing's. A role of genetics is also there because we do see some amount of heritability from one generation to the other. Medications and drugs of abuse, for example, steroids. Like we very frequently in the current COVID scenario do get references of patients suffering from depressive symptoms who are receiving steroid therapy for their COVID illness, and also neurological conditions such as post-stroke, Parkinson's disease, multiple sclerosis. So when you talk of any psychiatric illness, there is going to be a mixture of all these variety of etiopathological factors. Before we delve into this, we will talk about relevant neuroanatomy. Neuroanatomy of depression per se, if you see, there is always a level of circuit involvement of cortical along with subcortical structures. When we talk of cortex, as we know, humans are supposed to be one of the most intelligent species because of the highly developed frontal lobes that they have, particularly the prefrontal cortex, which is what differentiates us from apes and other primates as well. But I guess it does bring us with a horde of other illnesses related to this lobe as well. So the prefrontal cortex, as can be seen in this image, you can see the Sylvian fissure ahead of which is the motor cortex, after which comes the premotor cortex, and the entire area ahead of this is the prefrontal cortex, which you can see is divided into a variety of structures such as the dorsolateral prefrontal cortex, the ventrolateral prefrontal cortex. These are on the lateral view, whereas on the medial view, we have the dorsomedial prefrontal cortex, the anterior cingulate cortex, ventromedial prefrontal cortex, and this is the floor of the brain, which is just above the olfactory area. This will have the OFC or the orbitofrontal cortex, so just above the orbits of the eyes. So we have this cortical structure. So if you see, this prefrontal cortex is related to a lot of complex higher brain related functions. For example, the DLPFC or the dorsolateral prefrontal cortex is associated with cognitive control and solving of complex tasks. So it is primarily involved in cognition. The ventromedial prefrontal cortex, on the other hand, is related to generation of normal emotions due to its connections with the subcortical structures such as amygdala hippocampal complex. And it also regulates autonomic and neuroendocrine aspects because of its connection with the autonomic nervous system. So you can see here an area that is connected with emotions and also connected with autonomic arousal related to the emotions and response to stress, response to situations. The third area that we saw, the orbitofrontal cortex, is normally involved in correcting behavioral and emotional responses. So there is an aspect of social behavior, judgment, ethics, development of personality, which is associated with this area. And we can see that these areas, particularly the DLPFC and VMPFC, as we saw in this previous figure, are connected to each other with the anterior cingulate cortex and the hippocampus. So it will has a very important role in the pathophysiology of depression, as we will eventually see. So after we talk of cortical structures, the next in the sequence comes the subcortical structures, which includes amygdala, hippocampus, the thalamus, hypothalamus. These are the associated areas. So amygdala, as we classically know of, is associated with recruiting and coordinating cortical arousal and neuroendocrine response. So typically studies have shown that the amygdala lights up in the brain when a person is facing an ambiguous stimulus or a fear-related stimulus. And it is also connected with learning and memory related to emotions. So emotional memories are all storehouse related to amygdala. It is also seen in patients of depression that there is an abnormal level of amygdala activation, which has been seen to correlate with the severity of depression as well. It is particularly seen that patients of depression who have a lot of negative self-attribution, how you have patients who say कि मेरे साथ ही कुछ ठीक नहीं होता है, bad things only happen to me, my entire life is a mess, nothing good will ever come out. So the severity of negative attribution is somehow connected to the level of activation of amygdala. So that is how closely it is connected to the abnormality in depression. Next comes the hippocampus, which we know is a area which has a fundamental role in learning and memory. It is also important that this area is very rich in corticosteroid receptors, and it is linked very closely to the HPA axis via the hypothalamus. So we can understand that corticosteroid receptors and the cortisol response is related to stress. So stress has a role in the pathophysiology of depression, which goes and creates its action through the hippocampal pathway. This area is also a very active area for neurogenesis. It's one of the very few areas in the brain which even after adulthood continues to develop neurogenesis even in an adult active brain. So after hippocampus and amygdala, the other areas, accessory areas include the thalamus, striatum, pallidum, hypothalamus as we talked of, and prominently the midbrain structures, which are the primary storehouses of serotonin, that is the raphe nucleus, and noradrenaline, that is the locus coeruleus. And as we know, serotonergic activity and noradrenergic activity are the two things that are abnormal in depression. So the midbrain related structures with its connections to the subcortical and cortical structures are what would be considered primary areas which are associated with chemical neuroanatomy of depression. So as we saw, these are specific areas which are abnormal probably in depression, but it's not like one specific area is affecting one specific structure. It's actually a very complex pathogenesis where every area has feedback mechanism to other areas. The prefrontal cortex has a top-down control over lower brain areas such as the thalamus, amygdala. So, you know, cognitive control of fear, cognitive control of irrational thoughts. Then the area also has connections with the hypothalamus and the HPA axis through its mechanisms on autonomic system and arousal. And midbrain structures of your serotonin and noradrenaline also have two-way connections with the other areas. So you can see it's a very complex neurobiological mechanism. So talking about converging of this neurobiological evidence of depression, these are areas that we saw of. You either have evidences related to volume of these areas, which is something that is evaluated using structural MRI, volumetric analysis, or you have abnormalities that are associated with its metabolic activity, which is something that is found through functional imaging, such as functional MRI or PET scan, like Adnan told you about. So the current evidence shows us that all of these areas that we talked of have some kind of volume deterioration when a person is in an active depressive episode. It is also seen that many of these abnormalities get normalized after treatment with depression. So not all of this is irreversible, but then not all of this is reversible as well, because it is seen that with multiple episodes and even in relatives of patients of depression, some kind of these volumetric changes are also present, which means that some of these are there as a trait in these individuals and not just seen during a depressive episode. On the contrary, when you talk of metabolic activity, you can see that the anterior cingulate cortex, which we saw connected the DLPFC with the VMPFC, has an excess of activity. Similarly, the orbitofrontal cortex also has an excess of activity. Amygdala, as we had discussed, which is active more with a lot of negative thought process in depression, is also excessively activated. So these areas take up a lot of extra glucose as compared to the other areas when you are assessing using functional imaging. On the contrary, dorsolateral prefrontal cortex, which is involved in cognition, has a reduced activity. So you can imagine patients of depression who complain of poor attention, inability to concentrate, difficulty in remembering things, which can be understood as a byproduct of this abnormality. So this was about neurobiological changes. So DLPFC hypoactivity has a correlation with psychomotor retardation and slowing, as well as anhedonia in depression. Abnormal amygdala activation with depressive rumination. So the repetitive thought process that मेरे साथ ही बुरा होता है, मेरे साथ कुछ अच्छा नहीं है, मेरे लाइफ में ही प्रॉब्लम्स है, along with negative attribution, मुझे ही लोग ऐसा बोलते हैं. So having a negative outlook towards events, negative interpretation of events, and importantly, response to antidepressant is associated with reversal of structural changes in hippocampus, as well as the a reduction in the excessive metabolic activity, which was seen in amygdala and the anterior cingulate cortex. In fact, it is also seen that the normalization of the anterior cingulate cortex activity or the lack of it becomes a prognostic marker of depression. Meaning what? If you are giving an individual antidepressants and you see that the anterior cingulate activity is not really coming down to normal, it probably predicts that your drugs are not helping and the patient is not going to get better. Next, coming to neurochemical or hormonal abnormalities, the first of it is role of stress. So stress is a very general term which we all know of, but it more so holds true for psychiatric illnesses such as depression, where it has been seen that adverse childhood events, so events such as parental separation, loss of a parent, emotional abuse, physical abuse as a child, it is seen that these individuals tend to have increased vulnerability to depression in the adulthood. So you can imagine that stress that happens as a child somehow causes some changes in the brain, which makes these individuals vulnerable to getting depression in adulthood. This was one of the earliest things that was seen in research. Later on, individuals found biological proof of this because they saw that a lot of individuals with depression had HPA axis abnormalities in the form of raised cortisol levels. So we normally know that cortisol is an important hormone which is released during stress, be it physical stress or be it emotional stress. It is seen that depression-related individuals, at least 50% of it, have increased cortisol levels, and they also show abnormal dexamethasone tests. So the dexamethasone suppression test which we perform to check the abnormality of the HPA axis, it is seen that even this is abnormal in depression individuals. So it is basically to just give you an idea that the concept that psychiatric illnesses are just functional abnormalities and there is nothing really wrong in the brain is a very archaic and an old concept. We have enough evidence now that there are a lot of biological changes which happen, which we initially didn't know of. Next, secondly, there is an exaggerated HPA axis response to psychological stress. Meaning what? Normally, when an individual is stressed, there will be release of cortisol, and there is also associated levels of cortisols which then normalize once the stress settles down. However, it is seen in depressive individuals that there is an excess release of cortisol and exaggerated response to HPA axis, which takes a long time to normalize and which normalizes very slowly. This is thought to be associated with impaired glucocorticoid receptor functioning in the hypothalamus in the hippocampal area. So an abnormal GR functioning will lead to an abnormal negative feedback. This negative feedback will in turn lead to too high levels of cortisol in the brain. Thirdly, it is also seen that the failure of cortisol levels or the cortisol releasing hormone levels in the brain to normalize post-treatment is also a prognostic marker in depression. So it is seen that if you're treating a person for depression and the cortisol or CRH levels are not really coming down, it's possible that the person is going to end up being a treatment-resistant individual. So now we saw that abnormal activity in the anterior cingulate cortex, failure of cortisol levels to come down, failure of CRH levels to come down could be considered as chemical biomarkers related to prognostication in depression. Next, coming to immunological mechanisms. So these are also chemicals, right? So pro-inflammatory cytokines and sickness behavior. So we all know that in general, when there is some kind of pro-inflammatory activity in our body, be it a normal case of cough cold, we have a lot of associated lassitude, lethargy, drowsiness, irritability, which comes. Which is very similar to a person with a depressive individual experience. So this is one of the earliest kind of connections that was noticed, that increase in pro-inflammatory biomarkers has a connection with sickness behavior. Secondly, individuals such as those who have hepatitis B or C who receive interferon therapy, it is seen that externally giving an individual interferon, which is again a pro-inflammatory marker, leads to depressive individuals in these patients. In fact, it is something that is seen so commonly that we even get references from gastromedicine department in our hospital for individuals who are supposed to be started on interferon therapy or those who are receiving therapy just to see if they are experiencing depressive symptoms. Thirdly, it is also seen that severe depression is associated with immune activation. There is an increase in the levels of inflammatory cytokines, and these concentrations are high. So it is almost as if the depression that is seen in the individual is an immunological reaction that is ongoing. So this abnormality that is seen is again thought to be related to impaired glucocorticoid receptor functioning. So we saw that this GR functioning has a role in abnormalities in the stress response and the CRH and cortisol release, and it also has an abnormality in the immunological mechanism. So to converge on these two things, early adversity and early stress will lead to glucocorticoid receptor abnormalities, which happen at a genetic level. This can lead to abnormal CRH levels, abnormal activation of HPA axis, abnormal activation of the adrenal gland, excess levels of cortisol levels, excess in immunological reactions, excess inflammatory cytokines, and then cytotoxic response in the brain, and further an entire depressive syndrome. So you can see that something that starts secondary to emotional stress, something that starts to secondary to endocrine related abnormalities, something secondary to drugs, substances, can all lead to abnormalities in this pathway, which finally lead to the depressive syndrome. So a summary of the things that we discussed just now is that cortisol and CRH levels are increased in depression, pro-inflammatory cytokines are increased, brain-derived neurotropic factor, which is normally required for hippocampal neurogenesis, is decreased in depression, and serotonergic and noradrenergic response is reduced in depression. So this is a summary slide related to neurochemical abnormalities. Touching on heritability and genetics, only 37% of heritability is can be used to explain the depressive syndrome. So you can understand that almost 70% of the abnormality that happens in depression is not genetic. So it is something that is secondary to role of environment, early life stressors, drugs, medications, and neurological conditions, endocrine conditions, and all the entire basket. So genetics, they are related to a couple of gene-related abnormalities. We would go into this. Recent interest that has come in the concept of epigenetics, meaning what? That external abnormalities, like we talked of, such as stress, drugs, medications, can lead to permanent kind of alterations in the genetic level, secondary to DNA methylation related abnormalities. And these can, as a top-down mechanism, lead to abnormalities between all these mechanisms that we talked of. So when we say that stress ज़्यादा था बचपन में इसलिए किसी को depression हुआ, it is not something that is talked just in the air. There are actual abnormalities that happen at a genetic level due to an interaction between gene and environment, and this, as a consequence, can lead to abnormalities in the HPA axis, the stress response, immunological response, and so on. So one of the last slides is basically on integrating the evidence, all those things that we talked of till now. So genetics and environment, the two evils, I would say. It's a complex outcome of these two things, where early life stressors, recent stressors, and some kind of a genetic vulnerability, such as a family history in family members, siblings, can subsequently lead to abnormal increase in the pro-inflammatory cytokine levels, abnormality in the neurotransmitter transmission. There are abnormalities subsequently in the HPA axis, which leads to an excess levels of cortisol. Excess cortisol will lead to stress inflammatory response, hippocampal atrophy. This abnormal response will cause haywire of the feedback system, which will further lead to prefrontal cortex hypoactivity. So you have a complex acting frontal lobe, which is hypoactive, because of which your subcortical structures, such as the limbic areas, become hyperactive. And this entire cascade of events is something that leads to depression. Importantly, as you can see, everything has a bidirectional relationship. So you cannot really say that it follows this particular sequence. Excess abnormality in one can lead to some kind of an abnormality in the other through a feedback mechanism. So summarizing the points that we saw till now, etiopathogenesis of depression is not merely a couple of neurotransmitters. It is a very multifactorial entity with role of both genetics and environment in the form of physical and psychological stress playing a major role. Talking of neurotransmitters, serotonin and norepinephrine transmission primarily, along with reduced neurotropins such as brain-derived neurotropic factor, along with hyperactivity of the HPA axis, excess cortisol, and abnormal immune activation is something that is seen in depression. Next, associated structural and functional abnormalities in the corticothalamic striatal limbic neurocircuit. So the prefrontal cortex, hippocampus, amygdala, hypothalamus, and the thalamic areas. which causes a disruption in the balance of these structures. Next, hypoactive prefrontal cortex is not able to rather regulate the overactive cortical and limbic regions, and this leads to negative attribution, excess reaction to day-to-day life events, psychomotor retardation, abnormal concentration, sadness of mood, and the entire depressive symptoms. Importantly, antidepressants lead to increase in the and normalization in the monoaminergic transmission. As we know, SSRIs, SNRIs, and these medications lead to a normalization of these levels. Along with this, there is a normalization in the BDNF levels. It reverses some of the structural changes, not all. And importantly, it modulates this cortical limbic neurocircuit function, which has gone haywire in the depressive pathology. So this completes my presentation. These were some of the core references which would guide you towards further reading. Thank you very much. So we could take some questions at this point of time, if required, or else we will move on to the next session. We have Dr. Wahid Mohin here with us. We'll be talking about a neurological topic. Yeah, so I'll hand it over to the bearers.
Thank you, Dr. Sachin. Now I would like to invite Dr. Wahid Momin. Dr. Wahid Momin has done his MBBS from Shri Vasantrao Naik Government Medical College, Yavatmal. Sir has done DNB from Kanchi Kamakoti Child's Trust Hospital, Chennai. Sir has recently completed DM Neurology from Sher-e-Kashmir Institute of Medical Sciences, Srinagar. Currently, Dr. Wahid Momin is working as an assistant professor in the Department of Neurology from in the same institute. So over to Dr. Wahid Momin.
Thank you, ma'am, for kind introduction. Good afternoon, everyone. Today's my topic is Myasthenia Gravis, chemical neuroanatomy. So, outline of my talk is like first we'll discuss about the anatomy of the neuromuscular junction, followed by the anatomic physiology, and then electrophysiology of the NM junction, and then we'll discuss about the Myasthenia Gravis pathophysiology. In that, we'll discuss about the autoimmune myasthenia gravis and the congenital myasthenia gravis, and followed by the Lambert-Eaton myasthenia syndrome. So first about the neuromuscular junction. This is a specialized area where the motor nerve terminates on a skeletal muscle fiber, and here electrical impulses in the nerve fiber is converted into the mechanical contraction of the muscle. NMJ consists of the three parts. First is the presynaptic part. It is a motor neuron terminal, followed by the synaptic cleft, and third is the postsynaptic part, that is the motor end plate. So you can see this is the nerve, and followed by the this is the synaptic cleft, and this is the postsynaptic membrane. About presynaptic terminals, a myelinated motor neuron, which comes from the anterior horn cells of the spinal cord, reaches the target muscle fiber, and it loses the myelin sheath after reaching the muscle, and it divides into multiple branches, nerve terminals, which are called as the terminal buttons. And one motor neuron innervates multiple muscle fibers, but each muscle fiber has only one neuromuscular junction innervated by the one motor nerve. And at presynaptic terminals, there are the synaptic vesicles, which are 30 to 50 nanometers, and this each synaptic vesicle contains the 10,000 molecules of the acetylcholine. The membrane of the synaptic vesicles contains the specialized protein synaptobrevin and the synaptogamine. Also, there on presynaptic terminals, there are the active zones where synaptic vesicles accumulate and attach to the presynaptic membrane and release acetylcholine into the synaptic cleft. The active zones are composed of the PQ-type voltage-gated calcium channels and a family of proteins. The proteins present in the presynaptic membrane are syntaxins, N-ethylamide sensitive fusion protein, SNAPs, and snare protein. And these proteins are involved in the fusion, docking, and the release of the acetylcholine at the active sites. Testing. For the technical glitch, the active zones in the presynaptic membrane are composed of the mainly PQ-type voltage-gated calcium channels and a family of the proteins. The proteins present at the presynaptic membrane are syntaxin, N-ethylmalamide sensitive fusion protein (NSF), SNAPs, snare proteins, and these proteins are involved in the fusion, docking, and the release of acetylcholine at the active sites. The PQ-type voltage-gated calcium channel at NMJ are targets for the Lambert-Eaton myasthenic syndrome. A nerve terminal also has potassium channels on its membrane and contains mitochondria and endoplasmic reticulum. About synaptic cleft, it is a space between the cell membrane of the motor neuron terminal and the muscle fibers. It is 30 to 50 nanometers, and protein filaments are present there. These are collected together to form the basal lamina in the synaptic cleft. And acetylcholinesterase is concentrated there to hydrolyze the acetylcholine to terminate the synaptic transmission. About end plate, NMJs form an indented area or the trough on the muscle membrane, which is called as synaptic gutter, and the postsynaptic muscle plasma membrane further invaginates to form the primary and secondary cleft. This primary and secondary cleft increase the surface area of the end plate, and this surface area is used for the acetylcholine receptors and for the voltage-gated calcium channels. So acetylcholine receptors are present at the shoulders of the cleft, and the voltage-gated sodium channels are present deep in the secondary clefts. The important proteins at end plate are rhabsine and mus. Now about the nicotinic acetylcholine receptors, these are 5 million per junction. Half-life is 14 days, and these are ligand-gated non-selective cation channels. And these are the pentamers, like arranged as 2 alpha, 1 delta, 1 beta, and 1 is epsilon or the gamma subunit. And these are symmetrically arranged around a central ion channel. Acetylcholinesterase bind to the extracellular domain of the alpha subunit on the opposite sides of the channel 4, and
Also, in myasthenia gravis, IgG1 antibodies are directed against the alpha-1 subunit. SCHR receptors are anchored to the end plate membrane by the rhabdin protein. So rhabdin protein is for clustering of the acetylcholine receptors at the end plate. Binding of the acetylcholine to these receptors opens the channels, allowing the influx of the sodium ions from the extracellular fluid to the muscle membrane, and this creates the end plate potential and transmit the action potential to the muscle membrane. So about the anatomic physiology of the neuromuscular junction, acetylcholine is synthesized in the presynaptic terminal using choline and acetyl-CoA by the enzyme choline acetyltransferase. It is subsequently goes to the multiple modifications and it is packed in the vesicles. When the action potential travels from the nerve fiber, after reaching the presynaptic membrane, there is opening of the voltage-gated calcium channels. There is influx of the calcium ions into the nerve terminal. This causes vesicles to migrate toward the terminal membrane, and these fuse with the active zones. And there are like different proteins, vesicular proteins, and the help for the fusion and the release of the acetylcholine in the synaptic cleft. The released acetylcholine subsequently binds to the nicotinic acetylcholine receptors on the junctional folds of the motor end plate. The binding of the acetylcholine to the receptor triggers opening of the acetylcholine gated ion channels that allow the influx of the sodium ions into the muscle. The sodium influx changes the postsynaptic membrane potential from minus 90 millivolt to the minus 45 millivolt. This decrease in the membrane potential is called the end plate potential. In the NMJ, the end plate potential is strong enough to propagate the action potential over the surface of the skeletal muscle membrane that ultimately results in the muscle contraction. To prevent the sustained depolarization and persistent muscle contraction, the acetylcholine is hydrolyzed by the acetylcholinesterase enzyme into the subunits choline and the acetate. And choline is taken further by the presynaptic membrane for further synthesis of the acetylcholine. This is the physiology of the neuromuscular junction. So, like when the motor neuron action potential reaches the presynaptic membrane, there is calcium entry through the voltage-gated calcium channels. It leads to the release of the acetylcholine from the synaptic vesicles. After that, this acetylcholine joins, attaches with acetylcholine receptors at the postsynaptic membrane, and there is sodium entry into the muscle membrane, which causes local current between the depolarized end plate and the adjacent muscle plasma membrane. This followed by the muscle fiber action potential is generated, and which is propagated to the muscle plasma membrane. And after that, the acetylcholine is degraded and further taken in presynaptic membrane. So, in electrophysiology of the NMJ, when the nerve is electrically stimulated, neuromuscular transmission can be detected as a brief rise in the membrane potential called end plate potential. In myasthenia gravis, there is reduced postsynaptic response to the acetylcholine measured as a reduction in the amplitude of the end plate potential. In severe cases, end plate potential becomes smaller, and this may not reach the threshold for generation of the muscle action potential. The progressive failure of the action potential can be seen as a decremental response on the repetitive nerve stimulation test. So, myasthenia gravis is a disease affecting the neuromuscular junction, causing fatigable ocular, limb, and the bulbar muscle weakness. Prevalence is 1 in 5,000. It affects all ages, with peak in younger women and the older men. This can be generalized or localized to the certain muscle groups. Types of the myasthenia gravis are autoimmune, which can be due to anti-acetylcholine receptor antibody, anti-MuSK antibody, and it can be double seronegative. And other type is congenital myasthenic syndromes. So, antibody to the acetylcholine receptors and the MuSK are found in majority of the patients with autoimmune myasthenia gravis patients, but 50% of the purely ocular and 20% of generalized cases will not have any of these antibodies. These are called the seronegative cases. So, role of the thymus in the myasthenia gravis. The factors involved in the induction of autoimmune myasthenia gravis have not been fully understood. Approximately 10% of the patients with autoimmune myasthenia gravis have the thymoma, and 60% have thymic hyperplasia. And thymectomy produces a long-term benefit in many patients with the myasthenia gravis, which implies the role of the thymus in the pathogenesis of the myasthenia gravis. The possible mechanisms are like the expression of the self antigens by the thymoma cells and the impaired negative selection of the autoreactive T lymphocytes. Now we'll see the mechanisms of the acetylcholine receptor antibodies. These are the IgG1 and IgG3 class antibodies, and 85% of the patient with generalized and 50% patient with purely ocular involvement have these antibodies. These antibodies act by two mechanisms. First mechanism is complement mediated damage, and second mechanism is the internalization of the ACH receptors. In complement mediated damage, the binding of the antibodies through the ACH receptors, there is activation of the classic complement pathway, which leads to the formation of the membrane attack complex. Formation of the membrane attack complex leads to the influx of the sodium, influx of the calcium, which causes local damage of the to the membrane, and there is diminished response to the acetylcholine. It also causes loss of the voltage gated sodium channels, raising the threshold that the end plate potential must reach to trigger the muscle action potential. Bivalent ACHR IgG can also cross-link with the adjacent ACHR receptor, increasing the normally slow rate of the internalization and lysosomal degradation of the acetylcholine receptors. And the resulting loss of the acetylcholine receptors at the NMJ impairs the neuromuscular transmission. This becomes clinically evident as the fatigue and muscle weakness. So on this, there is left side, there is the normal neuromuscular junction, and right side, there is the neuromuscular junction in the myasthenia gravis patient. In myasthenia gravis, there is, due to complement-mediated damage, there is a loss of the acetylcholine receptor clustering at the postsynaptic membrane. Also, as it is bivalent, antibody is bivalent, it joins the acetylcholine receptors, and there is internalization of the acetylcholine receptors. So receptors will not be available for the action of the acetylcholine, and there will be decrease in the end plate potential, and followed this clinically will present as the fatigable weakness. So now we'll see the mechanism of the MuSK antibodies. MuSK is a transmembrane tyrosine receptor kinase that is crucial for the development and maintenance of the acetylcholine receptors clusters at the neuromuscular junction. It is of the IgG4 subtype with the relatively low titers of the IgG1 and IgG3. IgG4 doesn't have any property of complement activation, and it is a monovalent, so it doesn't cause the internalization as done by the anti-SHR antibody. So MuSK antibody causes disassembly of the neuromuscular junction by disrupting the physiological function of the MuSK in the synapse, maintenance, and the adaptation. So this is the normal neuromuscular junction. In this, the agrin is secreted by the presynaptic terminal, which combines with the LRP4. This activates the MuSK, muscle-specific kinase, and this complex causes phosphorylation of the MuSK and MuSK-related proteins like beta subunit of the ACHR and the DOX7. And after that, rhabsin is recruited to the phosphorylated acetylcholine receptors, stabilizing the postsynaptic clusters of the acetylcholine receptors. In myasthenia gravis, MuSK myasthenia gravis, IgG4 blocks the assembly of the agrin, LRP4, and MuSK complex. There is interruption of the MuSK kinase signaling, and there is slow disassembly of the postsynaptic SHR clusters. There is a decline in the miniature end plate potential and the end plate potential amplitude. There is failure of the muscular action potential and fatigable weakness. In double seronegative myasthenia gravis, the antibodies to the ACHR and the MuSK and to the MuSK protein will be absent. But some sensitive cell-based assays have recently shown that many of the seronegative patients do indeed possess autoantibodies against LRP4 and agrin. So LRP4 antibodies is a postsynaptic LRP4 is a postsynaptic protein crucial for the development and maintenance of the NMJ. It acts by the act as agrin receptor necessary for the activation of the MuSK. It is mainly IgG1 type, and inhibition of the agrin induced aggregation of the acetylcholine receptors at the neuromuscular end plate. IgG1 is a capable of activating complement and thus producing damage to the postsynaptic membrane folds via membrane attack complex. And other antibody commonly found is antibodies to the agrin. But this is seen in the small number of patients only. And agrin is responsible for activating the LRP4 and MuSK pathway. Next, we'll see about the congenital myasthenia syndromes. These respond mutations in the genes encoding proteins that are important for the neuromuscular transmission. Age of onset, it usually starts in the in perinatal period or the infancy, but it can start later in the life. The common like postsynaptic mutations are common than the presynaptic or the synaptic mutations. Postsynaptic mutations are seen in the 85% of the cases, and it can be seen in any 4 subunits of the acetylcholine receptors, rhabcin, SCN4A, that is sodium channel, MuSK, or the DOX7. Most commonly mutated gene is the ChRNE, which is encoding the gamma, or it is called epsilon subunit of the acetylcholine receptor. Other postsynaptic mutations are ChRNA1, ChRNB1, and ChRND genes, which are the mutations in the subunits of the acetylcholine receptors. And there are some mutations in the MuSK and DOX7 rhabcin pathway mutations and SCN4A mutations. Synaptic basal lamina-associated CMS is seen in 10% of the cases, and it can be due to the COL-Q gene mutation, in which there is end-plate choline esterase deficiency, and LAM2 gene mutations. In this beta-2 laminin deficiency will be there. Agrin gene mutations lead to the agrin anomalies. Presynaptic defects are seen only in the 5% of the CMS patients, and their most common is mutation in the choline acetyltransferase genes, leading to defect in the resynthesis of the acetylcholine. And other is paucity of the synaptic vesicles. For this, mutation is unknown. So these are the proteins and the genes associated with the CMS. So in presynaptic membrane, there is defect in the SCS resynthesis due to the CHAD gene mutation. And in synaptic, there is synaptic basal lamina associated CMS. There can be mutation in the COL-Q, LAM2, or the agrin gene. And in the postsynaptic membrane CMS, there can be the acetylcholine receptor subunit gene mutation, or there can be SN4A, rhabcin, or the DOX7, or the MuSK gene mutation. Last but not the least, Lambert-Eaton myasthenic syndrome. This is an autoimmune disorder. In these antibodies are there against the presynaptic PQ type voltage-gated calcium channels. There is impaired control release of the acetylcholine, leading to the muscle weakness. This disorder is thought to be the paraneoplastic. And small cell lung carcinoma is the most common association. Other associations are the non-small cell lung cancer, mixed lung carcinomas, prostate carcinoma, thymoma, and the lymphoproliferative disorders. In patients without cancer, some association with the HLA, B8, DR2, DQ2, and other autoimmune diseases has been found. Thank you.
Thank you, Dr. Wahid. Now, as we are coming to the closure of the ceremony, today's event, there's just one announcement that please solve the post test, which will be posted soon on the group and submitted. Now, before we end the webinar, I like to take the opportunity to express my gratitude to each and everyone who has contributed to the success of it. First and foremost, I, on behalf of Department of Anatomy, would like to thank our Dean, Dr. Ramesh Bharmal sir, to give us an opportunity to participate in the celebration of glorious 100 years of Nair Hospital. Thank you, sir, for your trust and encouragement. My heartiest thanks to all the speakers and the HODs, head of the departments of the medicine, psychiatry, and neurology of TNMC and Nair Hospital for collaborating with anatomy department. Next, I like to thank our head of the department, Dr. K. Shamkishore sir. Concept and topic of the webinar is his brainchild, which kept us on our toes throughout the preparation. I like to express my thanks to Dr. Yuraj Mosley sir for guiding us all throughout the preparation of the webinar. He was never tired to solve our doubts, though minor and serious doubts. He has a vast experience of arranging more than 100 workshops and CMAs. Thank you, sir. I would like to thank Dr. Shobha Gaikwad, organizing secretary of this event, and all my colleagues and staff of anatomy department for their tremendous help. And last but can't be the least, thank you to all the participants, without which this event wouldn't have been completed. Thank you so much for your overwhelming response. This webinar is declared as over. Thank you so much. Thank you from both of us, Dr. Shobha Gaikwad, Dr. Mrinalini.